Hello, welcome to your 3B Cardiology Revision Lecture for 2024. I'm Paige, I'm one of the fourth years. I'm just going to be talking about cardiology for the next, hopefully, 2 hours. The idea of doing this pre-recorded, though, is that you can pause it and come back to it whenever you want to. So if you're feeling like this is too long, please do just do it in small chunks, however works for you. So the way that today's going to work, I'm going to focus a little bit on the pathophysiology, just because I think it's important to gain an understanding of that, to actually apply it to when you're doing your exams. Um, and I'm going to go through the matrix for all the cardiology stuff right in order. If you want to, when you're going through the slides afterwards, feel free to jump through these different little links here. And of course, I'm only a fourth year. There's a good chance that there's some mistakes and problems in here. So if you have questions or if you found something that I can fix, please send me an email and I'll do my best to put out a comment that it's been updated. All right, so let's get rolling with arrhythmias. I think they're the hardest, so we'll get them over with first. So just a revision of the electrical conduction system through the heart. So of course we have our pacemaker potential that starts in the SA node, and then that gets sent down through the atria and across to the left atrium. From that point, we know that it causes the contraction of the atria. That way you can get the blood going into the atria before the ventricles contract. Blood coming out of the atria before the ventricles contract. And then we have the AV node, which again carries down the electrical current down into your bundle branches. So you've got your left and your right, and then they go up through the Purkinje fibers to depolarize the ventricles, and you get your contraction. And then we know how that corresponds to an ECG. Now, what I think you should go over is the slides. This has some ECG buzzwords, just so you can reflect back and think, if you see this sort of change on ECG, what the cause might actually be. So PR interval, so again, that's from the beginning of the P wave until the end of the beginning of the Q, which I find kind of odd. Anyways, if it's prolonged, that usually is due to an AV block. And if you see PR depression, that's often seen in pericarditis. I've got some images to show you later of that. With the Q waves, so these ones here, there's something called pathological Q waves. That's when they're more than 1 or 2 small squares below the baseline. Normally you expect them to be 1 small square or less. The number 1 or 2 depends on which lead it's in. I wouldn't pay a ton of emphasis on that. But generally they signify that there's been some past ischemic changes, so like usually a past AMI. For the QRS complex, I'm going to be going into more detail on that in a couple slides. For the ST segment, if it's elevated, obviously it could be a STEMI, but you have to keep in mind if you see it in multiple different leads and it's not following a specific pattern like you would expect to see from an AMI, then it's often due to myocarditis or pericarditis. And then similarly, ST depression could be an NSTEMI. I didn't put this on here, but it also could indicate that there's a STEMI in the inverse leads. So you might need to do a posterior ECG as well. And then pericarditis is another possibility for that one. And then there's something called a saddle ST, and that's in pericarditis as well. And I've got some pictures to show you. If the T waves are peaked, that's pretty common in hyperkalemia. And if you get QT prolongation, then that's often due to certain medications, a lot of the antidepressants or otherwise some antibiotics, or it can be seen in torsades de pointes. So that's when you start to get those changes that make you go from a nice normal QRS to it being slowly stretched out, and you're starting to get more like towards that VFib. Oh, right. I'm not sure how well you have an understanding of why we have the leads in certain places and why they correspond with certain vessels when we see ischemic changes, but I find this visual quite helpful. So I like to think about how the ECG dots are literally placed relative to the conduction system of the heart. So when we see positive inflections on an ECG, it's because the current from the electrical part of the heart is literally going towards that lead. So for example, we know that the current that's going through the heart generally goes from the top right segment down towards the bottom left segment. So just down this direction. So in that case, that would be positive inflection as it's coming towards like V1, V2, V3, which is what we see. Similarly, if you can keep in mind that you have these augmented leads, so like 1, 2, 3, AVF, AVR, AVL, Those ones look at different cross sections. So like one, for example, is a nice one because it really just does this transverse line across the heart. So in that one, you're going to be thinking about if it's positive, that is aligning with the direction. So again, if you can kind of think about the way that the current is flowing relative to that lead placement, I think it helps a lot. All right, let's talk about axis deviation because I find this kind of confusing. I think this is probably the easiest like cheat method of doing it, to be honest. Essentially, axis deviation just happens when the current is located in a certain part of the heart, more so than you'd expect to see. So for example, if we have an enlarged heart, often it'll be enlarged over more so to the left, right? You get that hypertrophic changes, then you'd expect to see left axis deviation because the current is flowing more in the left area than you would expect. So in this case, the leads that you're going to see those changes in are lead 1 and in this case, lead AVF, but they'll be in opposite directions. So the thumb rule, if you haven't seen this before, you're going to take your first thumb and that's going to be pointing in the direction of lead 1. And then you take your second thumb and they'll be pointing in the direction of lead 2. If they're going opposite, the current has they have left each other. So it's like a left axis deviation. And if they are pointing towards each other, you're going to remember that they're going to crash right into each other. So it's a right axis deviation. So here's a little chart that shows, based off of lead 1 and AVF, which directions correspond with which axis change. Here's an example for you. So in this case, this is an ECG with left axis deviation. So we'll take our first thumb. It's positive in lead 1, that top box. And then looking at AVF down at the bottom right here, that's negative. So it's going to be going down. So what are these doing? They are leaving each other. They have left each other. It's a left axis deviation. All right. The other thing that I think is crucial to know about ECGs, and hopefully you guys are on top of this by now, is learning which leads correspond with which vessel. I think it's something in third year you use, and then afterwards kind of forget about it until you have to come back and start applying it again to what those ischemic changes are related to. I don't think there's a great way of knowing this besides like really understanding that diagram I showed earlier, but if you like these kind of color-coded models, this one works too. All right, so let's talk about bradyarrhythmias. First, I kind of want to show you this flow chart that I inherited from another student. It's a good way of kind of thinking about what's happening in the different arrhythmias and what's the underlying problem. So in this case, we'll start with the bradyarrhythmias. So really, bradyarrhythmias happen because you either have like a sinus bradycardia or there's some sort of like a block. And that block can either happen at the AV node, in which case you're going to see some change in the PR section, or you're going to have a block that happens in the branches, and that's going to be seen in the QRS complex. Okay, so starting with just a regular heart block, AV nodal blocks. So obviously you have a block at the AV node, so you have your signal that's starting from the SA node, it can't get fully through, or it gets slowed down, or it just doesn't get through at all. So then you have changes to how the heart contracts. So in the different degrees of heart block, it's progressively getting worse. So in the first kind of heart block, first degree, that's when you have a PR interval that's prolonged. So that's more than 0.02 milliseconds. So that's here. I forgot to put in the number of boxes, so I apologize. I do not remember that off the top of my head. So that's first degree. All right, second degree is that you get that progressive PR prolongation, and then you get a dropped beat eventually. So you can see that here, it's short, getting longer, completely dropped beat. And then in your second degree, that's Mobitz 2, you're going to get that fixed interval and then a dropped beat. So this one is going to be a very consistent pattern. So you'll see like 1, 2, 3, drop beat, 1, 2, 3, drop beat, which you won't see in that progressive one quite so much because it'll be more based off of how long that elongation is going. And then the last kind, you'll notice that the P waves are regularly spaced apart and that the QRSs are regularly spaced apart, but there's no correlation between the two of them. So that's a complete heart block because they're literally firing from different pacemakers altogether. So in terms of what you actually do with like symptoms, for the first two kinds, so first degree and Mobitz 1, they're generally asymptomatic because they're getting normal cardiovascular output still, so you don't need to treat them. In Mobitz 2 and complete heart blocks, they will likely get like syncope, dizziness. They might feel palpitations or like feel like they have a skipped beat. These are risky and they will likely need a pacemaker, definitely for complete heart block and quite likely for Mobitz 2. So here's just a reminder of like the different treatments. And then the buzzwords for those like earlier types of heart blocks, it's often some sort of like athlete is getting like a health check, or someone's getting like a health check from work, or they'll say it's found incidentally. So they'll give you clues that like otherwise this person is healthy. So you know it's not going to be a Mobitz type 2 or like a complete heart block because they probably wouldn't be healthy. They'd be having symptoms. So based off of that, if there's syncope, you can probably expect it to be one of the last two, most likely a complete heart block. All right, next stage is the bundle branch blocks. So going back to that diagram, now we're at the point where we're having a problem in the QRS complex. So you know that with our bundle branch blocks, we use our William Morrow letters, which I love personally. I'll go through why we actually get those changes in a second. But if you don't know the whole William Morrow thing, the concept is that William has an L in the middle. So you know this is for a left bundle branch block. The W is the shape that you see in the QRS in V1, and the M is what you see in V6. So since W is at the beginning of the word, it's V1, M is at the end of the word, it's V6. It's kind of like a nice simple way to remember it. Similarly, Morrow, the R signifies that it's a right bundle branch block, and the M is what you see in V1, and the W is what you see in V6. So as you can see, there's a nice little M shape, there's a nice little W shape. In terms of why we actually get this, if this helps stick in your brain a little bit more, going back to the conduction system, we have SA node to AV node. Cool, that's all working fine. Then we go down through our bundles. So on this case, the right bundle is going very well, so that's fine. And then it comes up, Purkinje fibers, depolarizes, that's all happy. On the left side, you have a bundle branch block, which you can see here. So in that case, the way that the rest of the left ventricle gets depolarized is via the signal coming from the right. So the signal goes down and then it actually jumps across, like where that dotted arrow is, to be able to depolarize the left-hand side of the heart. So because of this, you see that V1, which again we know is like over on this side relative to the heart, is going to be having a negative deflection as the current's going down because it's going to the kind of like the wrong side. It's going to have a positive deflection as it's going back towards that V1 lead, where you think about where it's actually located on your chest. And then as it's going across now towards the left-hand side of the heart, so now going over this way, it's going to go negative again, and then it'll be back to normal. So that's why you kind of get that deflection, because it's jumping to the wrong side compared to what you would normally see in a QRS complex. And then here's a diagram that has the same thing for the right bundle branch block. So in terms of how you deal with a bundle branch block, you have to first rule out if there's a new left bundle branch block, that there's not also ST elevation and that, or like any symptoms of a STEMI, because it can be a sign of a STEMI if you see it. In terms of the other things, you can just basically anything that causes a structural change to the heart could cause changes to the electrical conduction. So like cardiomyopathy, hypertension then causes like your hypertrophy, heart failure can cause your dilation. Those sorts of things can all be contributors. And the management is just to treat the underlying cause. All right. So for the tachyarrhythmias, I think I was confused about this when I was in third year about this whole concept of like, what is an SVT? SVT really just means supraventricular tachycardia, right? So if you think about the ventricles, they start here. So supraventricular just means above the level of the ventricles. So it basically means there's some problem with like the SA node, the atria, or like the AV node. So it has nothing to do with the actual ventricular contraction. So if we go back to this lovely little chart, if there's a tachycardia, the next best question to ask is what the shape of the QRS is. If it is narrow, it implies that it's an SVT because your QRS, being the ventricular contraction, is preserved. So that signal is totally normal. Versus if it's broad, then there's a problem with the ventricles, in which case it's going to be one of these three, confirmed. So again, if it's an SVT, then you have to think about where is the problem coming from. So as we talked about the three parts of the SVTs, they can come from SA nodes, the atria, or the AV nodes. So let's rock through them. So sinus tachycardia, our favorite. Again, it's going to look totally normal. You're going to know this because you're going to look for the P waves. That's really the giveaway. So going through that flow chart, it's fast, narrow QRS. This is a regular rhythm. P waves before every QRS at that nice 1-to-1 ratio. Those are like all the features that you need for something to be a sinus rhythm. Keep this in mind because like this is a very viable answer for them to put on like an exam. So thinking about just like any of those sorts of causes, don't forget for PE, that's the most common thing that you're going to see is a sinus tachycardia. And again, sepsis, trauma, medications, all those sorts of things that can cause SNS activation. And your management of sinus tachycardia is treat the underlying cause. And you can give them a beta blocker if it's indicated, but generally fixing the cause will fix the problem. All right, so let's talk about AF next. So AF, again, it's tachyarrhythmia. It's a narrow QRS so that we know it's an SVT. The giveaway, though, for AF is that it's irregular. So the R to R interval between each pulse or each beat is going to be different. And then, of course, like the pathognomonic thing is there is no P wave. That's what makes it AF. So the causes, well, generally things that cause structural changes in the heart can cause that like stretching of the atria, which then messes up how the signals actually go through. So your causes are like prior ischemic events, heart failure, again, hypertension, that sort of thing. And then if you see a young person that has AF, the most common cause for that is having alcohol. So definitely look for that in stems. In terms of the management, these are kind of like the basic principles, and I'll go into them in more detail. But if they're hemodynamically unstable, you have to definitely electrochol cardiovert them. If they are stable, you will be considering your rate and rhythm control. For anyone that has AF, you have to think about anticoagulation, and then the definitive treatment for it is cardiac ablation. All right. There are the different types of like classifications for AF. So you have like your paroxysmal. So that's just like it comes and goes quite quickly. Like you only have symptoms for a short period of time. So within 7 days. Persistent is like more than 7 days. Longstanding is more than a year. And people can get permanent AF as well. I'm going to talk a little bit atrial flutter. And since the management of them is essentially the same, I'll talk about that together in a couple slides. So atrial flutter, again, it's tachy, it's a narrow QRS, so we know it's an SVT problem. It's usually regular though, like you'll notice that the beats come quite regularly and that you do have P waves before every QRS, but it's a weird ratio. So like in this case, we have like 1, 2, 3 P waves and then a QRS. So any of these ratios are quite common for AF. I think 3-to-1 is the most common. So you'll often get like an atrial rate of like 300, which is like the standard. And then you'll get that as resulting pulse rate is 150. So that's like if you had a 2-to-1 ratio, sorry. And then the classic is like it's a sawtooth pattern. So the way that this actually works in terms of like the heart, so you have your depolarization from the SA node and it goes down to the AV node. But basically the electrical current will go around the tricuspid annulus, which is like right around the AV node over and over and over again. So it has this like extra loop of excitement, which is why it's that like regular pattern because it's just like a cyclical thing. In comparison, if we're talking about AF, generally it starts from like some other random pacemaker spot, often in the left atrium. So different from the SA node, like often it's in the left atrium. You can get it starting from the right atrium as well, but it's just like from another pacemaker. Okay. The causes for AF. So again, any cardiovascular condition or operation that can damage the nervous supply. Really similar concept. And then, yes, that is our management. So if we talk about conversion, what that actually is, we have to consider how like cardioversion and coagulation play a role together. So the biggest thing to know is that when you cardiovert someone, it can cause emboli to flick off into the body so you can have your risk of stroke and everything. So the guideline is that if you've had this arrhythmia, like symptomatically for less than 48 hours, then it's safe to do cardioversion because they're suspecting you wouldn't have had enough time for an embolus to build. But if it's been more than 48 hours, you have to do a transesophageal echo, so a TOE, or wait until you've had at least 3 weeks of anticoagulation to be able to do the cardioversion. And then after any cardioversion, you must anticoagulate someone for at least 4 weeks. So there are different ways you can do it. You can do electrical. So that's when you zap somebody. That requires an anesthetic. So as I say, often they use like just propofol, just like a quick anesthetic. Or you have your medication concepts. So they have different antiarrhythmics that are used. So flecainide, amiodarone, or the classic like pill in a pocket is flecainide that's as a tablet versus the other ones as an infusion. So the way that you decide which one that someone's going to get is just based off of the ejection fraction. So if they have good ejection, they can get a flecainide infusion. If they have bad ejection, they get an amiodarone infusion. And then this is just a view of your antiarrhythmic classes. Okay, cool. In terms of maintenance meds, this is once they're hemodynamically stable, your targeting rate and your targeting rhythm. And this is for both AF and atrial flutter. So in terms of your rate, your first line option is a beta-1 selective beta blocker. So that's either atenolol or metoprolol. In the future, if you have to pick one, atenolol is better because you can just give it once daily. Metoprolol, you have to take 2 doses. So fewer pills, may as well do atenolol. The other options is you can have your calcium channel blockers like verapamil or diltiazem. So those are the cardiovascular or like centrally acting cardio ones. Or you can have digoxin, that also works, or amiodarone, but that's pretty uncommon. And then in terms of your rhythm control, sotalol. So don't be fooled. Even though this is a beta blocker, it's technically a rhythm agent rather than a rate agent when it comes to AF and atrial flutter. Keep that in mind. Or you have flecainide, which we talked about in the previous slide, or amiodarone. And then I think the biggest thing to remember with amiodarone in terms of side effects is it can cause thyrotoxicity. And of course, the ADR of any antiarrhythmic is an arrhythmia. Okay, in terms of who needs coagulation, this is when you use your CHA-2DS2-VASc. So CHA-2DS2-VASc is specifically for people that have AF or atrial flutter, and you're trying to decide what their risk of stroke is. So it's only used in that situation. You can't just use it for anyone for knowing if they need anticoagulation. It's specifically for AF or atrial flutter. So you have all your different points here. And then here's what you can actually interpret them as. So if it's a male person, they would, if they get 0 points, or if it's a female person and they have 1 point, then you do not anticoagulate them. I should say anticoag instead of coag, sorry. So you consider anticoags for someone that's a man with a score of 1 or female with a score of 2. And then you definitely should coagulate them if it's over 2 in a man or over 2 in a female. Great. Obviously you have to weigh this up with their bleeding risk. So you can use has bled. That's what this table is here. So again, they have the points as well. So you might see some clinicians have to do that weighing up, especially if it's an older person. You'll notice that a lot of the risk factors are the same, which is a bit problematic. All right. In terms of the actual medications that you use, so you can use your DOACs, that's your direct oral anticoagulants. So that's the ones that we're talking about when we're using this chart here. So again, if we say, yes, you should really anticoagulate them, this is what you use. So DOACs are good. They're as effective as warfarin, but they have a lower risk of bleeding, which is why they're generally chosen. But the dose that you give really depends on the creatinine clearance. So in older people, bad kidneys, you have to really figure out what dose they should be on. So these are your dabigatran, apixaban, and rivaroxaban. And I love the names for apixaban and rivaroxaban because they have an X in them and they work on factor 10. So like Roman numeral X. So that makes sense. We love that. They do have reversible or like reversing agents for each of them. So one's called Praxbind, one's called Endexa. But generally it's a problem because you can't just like stop these medications and then go right into theater. If you do have like a need to go to theater, you have to usually stay off of them for a couple days to change your bleeding risk. But just know that those do exist. You'll see that maybe in clinic in the future, but I think they're still pretty new. And then warfarin works by acting your vitamin K reductase. So that's part of the extrinsic pathway versus the other ones are part of the pathways once they like come together here. And I think the important part for this one is that patients that have rheumatic mitral valve stenosis or mechanical valve automatically need warfarin. They cannot get DOACs. Stroke is definitely the top cause of death in atrial fibrillation, and anticoagulants reduce this risk by 70%, which is why everyone that has an arrhythmia, so like AF, should be on an anticoagulant as long as they qualify. All right, and then the ablation concept. So it's a percutaneous catheter, goes in. They literally go into the left atrium where it's most likely that you're going to be having those other pacemakers, and they just like burn them off. So kind of cool. All right, next let's talk about AV nodal reentry tachycardia. This is also called reciprocating tachycardia. So again, it's tachy, it's narrow, so we know that's an SVT. You'll see it's more of a regular rate, like here on the bottom, that's very regular. So the kind of buzzwords for what you're going to see in ECG is you can get like a pseudo P with a little hash, or a pseudo S in V1. So they have this like here that's supposed to be the pseudo S. Honestly, I think they're just words. But you can get a retrograde P wave. So that's like these little ones here. We get like the P wave after the QRS. Like see how it looks like they're kind of like coming afterwards. But this is quite common. It's usually from a genetic cause or alcohol or stimulants or exercise. So again, all those things that increase your SNS. The way that it works, I have a better diagram on the next slide if you want to take time to go through it, by the way. Reading through this was helpful. But in short, you have the fast pathway through the AV node and the slow pathway through the AV node. And what happens in the reciprocating is that you have a blockage in the slow pathway. So then it actually just goes down through the fast pathway, hits that blockage, and then comes back up through the fast pathway. And you kind of get this like it goes back and forth and back and forth and back and forth. So you get that early or that weird depolarization quicker than you should. The management for this is either adenosine or a vagal maneuver. So this one's cool because I'm not sure if you guys remember what a vagal maneuver is, but it's when you're essentially increasing your like intrathoracic pressure, and that that can cause you to basically get out of this rhythm. So a good example of that is having someone like pinch their nose and blow like that, you're increasing your pressure. Or if you think about someone like straining on the toilet, that's also like a vagal maneuver. So like any sort of that mechanism increases pressure and can cause you to come out of this. So that's a good buzzword to remember as well. But yes, management is just adenosine. All right. And then the rule of thumb, if someone is cardiovascular unstable, so like their blood pressure is tanking, they're confused, they have really weird VBG, they've got really bad chest pain from this arrhythmia that they're having, generally it's time to do cardioversion. All right, Wolff Parkinson's White or WPW. This one again is usually tacky, but it can be just like a normal like 60 to 100 beats per minute. And it can be regular or irregular, which is not helpful. But the way to differentiate this from AF is that there will definitely be P waves present. The key for this one is that it has delta waves. So that's this little sloping up situation going on here. So this one again is via an accessory pathway. So the difference is you start, actually I like this image pretty well. So you start like at the SA node and your atria contract like normal. And then the signal will go down through the AV node as it normally does. But then there's some other accessory pathway that completely bypasses the AV node and then causes some early depolarization. So that's how you get that sort of problem. The main cause for WPW is that it's genetic, we think. All right, so let's talk about our ventricular tachyarrhythmias now. So we're down to this stage. So we're done with all the narrow complexes. Now it's going to be broad complexes. So moving on to ventricular ectopics. So again, these are a wide QRS so that we know it's a ventricular problem. Usually they happen to most people. So you could be having them during the day, not be symptomatic from them. If you are symptomatic, it'll feel like a missed beat or a skipped beat. Generally, they're caused by things like coffee and alcohol. So the way that it actually works is that you have this basically extra locus in the ventricles that are causing their own little depolarization spontaneously, but just happens as like they just fire on their own. But what you can get is this period afterwards where you have that like skipped beat or like a prolonged rest period. During that time, it can look on ECG kind of like someone's having a heart block, but you'll know that it's not because it'll be this wide QRS that is preceding it. So don't get that mixed up with a heart block. In terms of what to do about it, if they have more than 100 in a day, then that can be justification to refer them to a cardiologist. But if it's less than that, generally you wouldn't do anything. And you can potentially use beta blockers to reduce symptoms, but that's probably up to the cardiologist. In terms of ventricular tachycardia, or VT, has this very remarkable type pattern, tachycardic. It'll be a wide pattern, so we know it's a ventricular problem. And the way that you can differentiate VT from other things like VFs or torsade de pointe is that it will be regular usually. So like in this case, you can see how it's regular. Here, it's got a slightly different shape, but it's still regular. So keep that in mind. The causes for this, again, all kind of depend on things that cause damage to your electrical conduction. So ischemia, QT prolongation, cardiac surgery, those are probably the big ones. Inflammatory causes like rheumatic heart disease are probably a little bit less likely, but still possible. The way that this actually works in terms of a rhythm is basically just having the ventricles contracting totally on their own and the atria being completely useless. So the reason that this happens is that you'll have an area in the ventricles that's damaged or stressed. So that can be like, again, any of these sorts of things. And then we know this is the myocardial depolarization pattern that's very quick, right? Like we want it to be quick so that it causes that uniform contraction in like one direction. So since this is so quick, it actually happens faster than you get your SA node activation. So the like actual depolarization pattern takes much longer in the SA node than it does here. So that's why you get that really tachycardic pattern, because it's just from like the myocardial cells just contracting, contracting, contracting. Cool. Moving on to the other ones. So again, you have your VT, which is this pattern, and then as you get lower on this chart, you'll get to the worst patterns. So your next worst one is torsade de pointe, and then your next big bad one is your VF. So again, they have the same sort of causes to them. And the management for any of these is going through your doctor's ABCD. They all require shocking, and you want to fix your underlying causes. And as I mentioned, these patterns are less likely to be regular than having your VT. Also with torsade de pointe, they'll often say that like it has this wave type pattern. So you can see that the amplitude is up, and then the amplitude is smaller, and then the amplitude is greater, and then smaller, and then greater and smaller. So that's kind of the defining feature of it, versus VF has very little regularity to it. I think this is probably the most normal looking VF. Often they're just like very random squiggles. In terms of your 4Hs and 4Ts, these are the reversible causes in like a cardiac arrest symptom or situation. So you have your hypovolemia, hypoxia, pH, so like acidosis, hypo or hyperkalemia, and hypothermia. I realize now that this chart actually has 5 of each, but generally we call them the 4Hs and 4Ts. For Ts, you have your tamponade, toxins, tension pneumothorax, thrombosis, and then they put another thrombosis in there. Okay, the next pattern to talk about in terms of actual physiology, though, is going to be VF. So with VF, the way that it works is that you get similar to how like the atria can fibrillate and just have these like stupid little contractions that are not actually going anywhere. That's basically just what the ventricles are doing. So they get so irritated that they can't even form like a uniform contraction like they're meant to. They just contract totally randomly. And then in terms of when you defibrillate for VF and VT, you definitely do. Asystole and pulseless electrical activity, they'll be shortened to PEA often. You do not, because it's not going to make a difference. You don't have enough like regularity or any like enough electrical conduction to actually be able to create normal rhythm again. And in terms of like what the difference is between cardioversion versus defibrillating, I didn't really understand this until recently, but they're not the same. So when we cardiovert someone who's in AF, it's not the same thing as shocking someone like when you're doing like a cardiac arrest situation. So in cardioversion, it's a synchronized shock, because since they're still having normal heartbeats, that's going to be synchronized to like match their heartbeat. So it'll only go during that like R wave of the QRS, versus asynchronous, it'll just deliver a shock at whenever it determines it's the right time. They're saying, okay, yes, this is shockable. It gives a shock. So cardioversion is much lower amount of energy versus defib is much higher. And obviously, if someone's doing cardioversion, we're not doing CPR on them ahead of time. If you're doing CPR, that person better be like properly arresting. Yes. Great. So that's it for arrhythmias. We're going to move on to coronary heart disease. Again, pause here if you want to take a break, or we can keep going. I think this is pretty important to know. This is the basis of atherosclerosis from like a pathology perspective. So what happens is when someone has things like hypertension and hypercholesterolemia, I'll start with hypertension because that's a better example. You get these shear forces from all the excess blood that go on the inside of the vessels. So your endothelium gets quite stressed. So what happens at that point is you get all your like inflammatory markers start to increase from the inside of the vessel itself. And like histologically, we start to see that you get that like macrophage infiltration, and you can get some of these like foam cells that start to develop. The next stage, as it progressively gets worse, and again, you have all your like cholesterol deposits, is you get this like fatty streak. And then after you have your fatty streak, you'll get like proper pools of lipids. And then after that, you get what's called an atheroma. So you have like your fibrous cap, and then you have some of that like fattiness on the inside. Then you get the next stage is called a fibroatheroma, and then similarly you have like you're starting to get that like calcified cap with all of that lipid tissue on the, or not really tissue, but like lipid material on the inside, and then eventually that can rupture, and that's an unstable plaque, and then it can like come off essentially like as a clot. So the way that we grade stenosis, which is just the narrowing of vessels, is using this chart here. You'll notice that generally we don't actually care about it until it's more than 70% occluded, which is kind of shocking when you think about it. Like in this case, this vessel is probably now 70% occluded. So until that point, you're probably not going to get symptoms from it. All right, let's talk AMIs. I miss Magic School Bus. All right, so let me just get this out of the way. So AMIs, so that's a spectrum. By the way, I borrowed some of the slides for AMIs from one of the other past like VPALs, so I can't take credit for all of this. So it's like a spectrum of your acute myocardial infarction. So you have ischemia, but it can be to different degrees. So I put on here the like 5 different kinds of myocardial infarctions, just to keep in mind that you have lots of different causes, right? Like you can have clots causing them. It can be due to ischemic changes, like from like anemia on its own, when you have just like increased demand, but the supply is not meeting it. Lots of those different sorts of things. So in terms of the actual spectrum of AMI, that includes unstable angina, and STEMIs. So as we know, you get that rupture of the atherosclerosis that forms a clot that blocks your coronary heart vessels, and then you're not getting enough blood flow to actually feed the myocardium. And then that part of the heart gets ischemic and cannot contract. This is why it becomes an arrest eventually. Great. So in terms of the not too bad to very, very bad, we have stable angina, unstable angina, and STEMI. The main things that differentiate them, so stable angina versus unstable angina. Stable angina will get better if you rest. Unstable angina will not necessarily. So if it lasts more than 10 minutes, that's concerning for stable angina. Or if they take their medications and they're still not getting better, that is also concerning. In unstable angina, generally you still don't see any like troponin changes, but you can get some ECG changes. You can get a bit of like ST depression or some like ST inversion in certain areas. And NSTEMI obviously is more severe. So at that point, you're actually going to get some damage to the myocardium. So you're going to have positive troponins. Again, that's released whenever there's actual like myocardial damage. And then the ST depression, you're going to see localizing to whichever like vessel is being occluded. And then STEMI, as we know, it's gonna be the same thing, except for this time it'll be an ST elevation. And don't forget, you can get ST depression in the leads that are opposite. So like literally across from that part of the heart. Here's a good way of like going through it if you're not too sure. All right. I think this is a good idea to understand like the concept of how the actual infarct is happening. So unstable angina, you have an increase in demand but you're having still enough blood flow. So it's just the problem is you increase your demand, right? Like you're exercising, you're doing something. Once you rest, your demand lowers down, so you're getting back to enough blood flow, so then your symptoms go away. In unstable angina, it's a problem with the supply, but not to the degree that you're actually getting any like actual infarct in the myocardium. In an NSTEMI, you get this like endocardial infarct. So it won't be the entirety of the myocardial wall, it'll just be the endothelial aspect or endocardial aspect. And then for a STEMI, you'll get the full transmural thickness that is being impacted. All right, we already talked about this, but if you wanted to read it a little bit more, so I'll keep that slide in there. In terms of the symptoms of any of these AMI presentations, they can be similar all the way from angina up to a STEMI. So it's good to differentiate using troponins and that ECG changes. So you get that like classic crushing retrosternal chest pain, you get your radiation down to the left arm, neck, jaw, interscapular area. And keeping in mind that for women, elderly, and diabetics, you're more likely to get different presentations without that pain, more likely to be just like nausea, diaphoresis, those sorts of things. So the reason that for diabetics you'll get those different presentations is that you get autonomic nerve damage from the actual diabetes itself, similar to how you can get like all your peripheral nerve damage as well. So that autonomic nerve damage means that nerves such as like the phrenic nerve, which is what normally gives us that left arm distribution for like cardiac pain, instead you're not going to get that because like the referred pain system is not going to work the same way. You can get also just like the regular symptoms, nausea, vomiting, diaphoresis, syncope, palpitations, anxiety, shortness of breath, all that sort of stuff. Cool. Here's a nice differentials list. I'd personally practice doing these yourselves because I think that's going to be your best learning. But in case you want to have a look at that. In terms of what you actually do about it, obviously the basics are ECG and troponin. And if those are positive, then you can do your send off to the cath lab for your actual management. And then in terms of just like ruling out any other causes, a blood sugar level is always indicated in any sort of like emergency situation. And then going onwards, you do serial ECGs like every, I don't know, a couple hours, I suppose, hour. And then your blood tests. So that's the troponins you're going to be keeping those up every few hours because usually you don't see a peak until like, oh yeah, 12 to 24 hours, they have it on there. But yeah, so you'll see like a slow increase and then eventually it'll peak and then it'll come back down. So like often for NSTEMIs, when they're doing a bit more like conservative management, they'll just like monitor the trend at the peak to see where they're at. In terms of blood tests, like you can do these in the long run. That's not going to be that useful in the short run. And we don't really need to talk about the imaging for this. All right, what we do need to talk about though is your management. So you can use that acronym MONASH. So M is for morphine. This works in two ways. One, obviously it helps with the pain that they're having, which will then cause them to like physically relax better, and then they'll get better vasodilation. And then second, morphine itself actually causes some vasodilation. So that's great because you're going to increase your blood flow. If they are having very low oxygen sats, so less than 92% on room air, you can give them oxygen. But if they are over 92 but still low, you don't have any indication to give oxygen. That was like the old guidelines were to always give oxygen, but that is not a thing. They found that actually causes oxidative damage to the heart. Next, you give nitrate, so like your classic like GTN, you can give that IV, or if they have their like sublingual one because they have angina, they would just use that. And then in terms of the next stage, you always give aspirin, plus or minus clopidogrel. Again, that's kind of up to the local guidelines. But the number one thing that actually makes a difference in terms of how much heart gets damaged is the time to PCI. So that's percutaneous intervention. So the aim is to get there within 90 minutes. If you cannot do it within 90 minutes, or if you cannot do it, sorry, within 12 hours, then you'd give thrombolytics. So I'm out in sale right now, so we'd probably do that. Cool. In terms of like monitoring, you keep them on telemetry going forwards because you can get all these arrhythmias due to the ischemic changes, which we just talked about. And then in terms of long-term management, you can use your SAB. I'm not sure if you guys have heard that acronym before, but it stands for SNAP-W. So that's like all your classic lifestyle modifications. And that SNAP-W is actually something that RACGP uses as their like acronym, which is kind of fun. Sorry, the second S in SAB is a statin. So you give very high dose statins initially, so like 80 milligrams of like rosuvastatin or atorvastatin, sorry. And then you'd use aspirin, ACE inhibitors, beta blockers, clopidogrel, because you need dual antiplatelet therapy 1 year after having an AMI, especially if you get like stents and that sort of thing put in. And then GTN as needed. So that's kind of the classic discharge after an AMI, what they need to be on. All right. So if we go to the next stage of actually talking about how to do your lipid management for atherosclerosis, I just put this in here to talk about the drugs. Obviously, we do our SNAP-W as a first line, and then past that, statins are great. So statins work first by lowering cholesterol, but second, they actually help to stabilize plaques. So you're less likely to get that plaque rupture, which is why we like to use them. So it's really recommended that for patients who are on them, they don't cease them, because when they cease them, even if their cholesterol is good, they're more likely to have instability in their plaques and get those ruptures. It can cause some rhabdomyolysis, or in some people, just more like mild muscle pain. So if they are having muscle pain, check their CK, like creatine kinase, because that's released during muscle breakdown, and then you can see if that's what's actually going on. And it's recommended to take it at night because that's when most of your de novo cholesterol synthesis occurs. Cool. And it works by inhibiting HMG-CoA reductase. In terms of your second line, what you do is you keep the statin and then you also add on ezetimibe, and it works by reducing cholesterol absorption, but it doesn't have the bonus of stabilizing plaques. And then third line, this is called a PCSK9 inhibitor, and it just reduces the number of LDL receptors, increases the number of LDL receptors, so you can actually just take LDL out of the blood system, essentially. And again, that would be added on top as like a third agent. And the way that we determine this is based off of their CVD risk factors. So if someone is very high risk, then their target is going to be lowest. So generally we recommend like 50% reduction from what their baseline LDL is, or less than 1.4, which is stupidly low. So either of those, whichever is lowest, is your target. And if someone is slightly lower risk, then it would be 1.8, and there's like a whole guideline to go through. Yes, I put the other ones in here. So again, like as your risk goes down, your cholesterol cutoff is allowed to be higher. In terms of what PCIs actually are, I'm not sure if you guys have had the chance this year to see them, but essentially they just go in your femoral artery generally, or sometimes they can go in like a radial artery. That's pretty uncommon. And they just like follow all the way up with a wire through to the heart. And then they're able to deploy these stents, which basically just open up the vessels wherever they need to. And then here is the pathology stuff for the like post-AMI damage. I would say just go through this. I don't need to read it out for you. All right, and same thing for this with the complications. I don't think there's like a great way to really like remember these. I think you kind of just need to just study them and know them. I'm sorry, don't have anything great. Any tips for these? All right. Yes, cheesecake is good. All right, moving on to vascular disease. So we'll start with peripheral vascular disease. So this is your classic 5 Ps, so pain, pallor, pulse, paresthesia, and paralysis. These are the symptoms that you get when you have peripheral vascular disease, meaning that you have got atherosclerosis and some of your distal vessels, basically just meaning you're not getting blood supply to further parts of your body. So classically, you'll see this in the legs first. Earlier signs is you'll get like your intermittent claudication, that sort of thing. And the pathology of it is the exact same as what we were talking about with atherosclerosis before. So the way that you actually diagnose it, so you want to be considering what their cardiovascular risk factors are. So again, if someone tells you that they're a smoker, you know, all of their other metabolic problems, pretty likely. The classic is, as I said, intermittent claudication, your 5 Ps, and then the definitive is doing ankle brachial index. So something that I find interesting is that normal is like 1 to 1.4. But if you have a low score, so your ankle blood flow is much worse than your brachial blood flow, that indicates that you have some significant like atherosclerosis because you've got that like stenosis of the vessels, that narrowing. But if the ratio is higher, it's because you're more likely to actually have high blood pressure in the ankles due to vessel hardening. So in that case, you've probably got atherosclerosis, but it's more of like a calcification. So either of those is bad. And they literally do just put like a blood pressure cuff on the ankle and monitor it similarly to how they do like a brachial one. And if you did want to send someone off to get surgery to get this corrected, generally they'll ask that you do an angiography first because you can actually see where the blood flow stops. So like this is a really good one where you can see the dye and then it just stops because you're not getting any perfusion. In terms of management, you obviously monitor your cardiovascular risk factors as best as you can. You can use your vasodilating antihypertensives. So that's like amlodipine. They literally just like open up your vessels. So that's great for this sort of thing. And yeah, like using your anticoagulants, treating any pain. People can get severe pain with this, and that might actually require opioids. And preventing infection, because if you can imagine you have very poor blood flow, that infection is not going to heal at all. But definitively, as you do vascular reconstructions, they have all these fancy grafts and that sort of thing. I haven't seen any vascular surgery, but it sounds cool. All right, we're going to move on to aortic aneurysms and dissection. So the underlying pathology of how this works, so we know that an aneurysm is basically just get this like ballooning out of the vessel. But the way that that is actually caused is that you have chronic inflammation. So like smoking is a very good example that causes like degeneration of your connective tissue. So like your elastin and collagen fibers are going to get weaker, which is going to cause that ballooning to happen. So you have other risk factors like Marfan's, for example, or like Ehlers-Danlos probably is like problems with connective tissue. So you're not going to have that support. And then when you mix that with your increased blood pressure, you get the ballooning out. Once you have an aneurysm, it's obviously at risk of dissection because it's a thinned area with a lot of blood going through it. The place where it actually happens in the aorta is between the within the tunica media. So it actually kind of happens like right around the middle part of that muscle layer. So you have different shapes of aneurysms. So like a true aneurysm is what we've been discussing. But you can have a dissecting one, which is where you get the blood going out through the into the like tunica media. So it like forms this little pocket, like leaflet area, and the blood goes out. And you can have a false aneurysm, which is like similar to that as well. Some other risk factors for having dissection or having an aneurysm. So being male, being of an older age, having coarctation of the aorta because it's going to be putting more strain on that part specifically and the parts before it. And as I said, connective tissue diseases. Cool. Here's a better example of what I was trying to explain on the last slide, or the slide before that, about the different kinds of aneurysms. So you can get this formation of like a false lumen and a true lumen. So the true lumen is like where the lumen's meant to be, where blood's meant to be. And the false lumen is an area where blood has leaked into, and now you get this extra like pocket where blood's going, which is a problem because it's pushing on the true lumen and actually causes the true lumen to collapse to some degree. And obviously the blood that gets stuck in the false lumen isn't going out to supply the rest of your body. So it's quite a waste, really. So there are certain places that you're more likely to get them. So for a AAA, so an abdominal aortic aneurysm, it's most likely to be infrarenal. So just right below the renal arteries. So like in this area here. And then for a thoracic aortic aneurysm, it's most likely to be in that first segment, so the ascending aorta. All right, so if we're talking about actually what the problem is for aneurysm versus dissection, aneurysms are urgent, like you need to deal with them because the blood's not going to the right spot and it's just kind of pooling and you're at risk of dissection, but it's not an emergency. Versus a dissection is like you need to get on a helicopter right now and go to the nearest trauma or vascular center. And they present differently. So an aneurysm, you can be totally asymptomatic, or you might just have some abdominal discomfort, like kind of like a bloated sort of feeling, or some back pain, because again, the aorta is quite retroperitoneal. Versus in dissection, you're going to get that 10 out of 10 tearing back pain. And it can come either from chest or abdomen or back, wherever the actual problem is. In terms of vitals, your vitals will be fine in an aneurysm. In a dissection, you're going to get like a wide pulse pressure because if you think about it, your heart is trying to get more perfusion, so your blood pressure is going to be high for that systolic, but then the diastolic, normally the pressure comes from that of the aorta contracting. So now if you have this blood pooling outside because you've got a dissection, you're not going to get that diastolic pressure like you normally would. You'll also get like an asymmetrical blood pressure between your right and left upper limbs. I think I've got a diagram to explain that better in a minute. And then in terms of exam for aneurysm, you can feel that like classic pulsatile periumbilical mess. And if you listen with the bell of your diaphragm or the bell of your stethoscope, you can hear some bruits usually. Actually, I think that one you can hear with your diaphragm. Sorry, yes. And then for dissection, they'll be, showing all those like pre-arrest type signs. All right, so here's my diagram for why you get that change in blood pressure between right and left when you have a dissection. So say, for example, the dissection is this like dark red bit here. We know that your blood comes up through the left ventricle and the aortic arch, and it's going to go out to supply the right arm first because you can get that blood flow through the brachiocephalic trunk before it goes out to the left subclavian, which supplies your left side. So the people on the right side would be like normal or maybe even a little bit high. However, the BP on the left side, if this is where your dissection is, you're going to get you can get things like this where basically the false lumen where the dissection actually is happening causes compression on the true lumen. So you actually get like impaired blood flow to all those side branches, or you can even get like a thrombus formation that causes damage to those side branches. So as you can imagine, if you've got some problem where you're not getting perfusion to the left subclavian, the whole left side is going to be poorly perfused. So you'll have low BP on that side. This isn't going to happen if you have an aortic aneurysm, though, by the way. It's only going to be thoracic. Cool. In terms of investigations for an aneurysm, what you're going to see, so like if it's a thoracic aneurysm, you might get this widened mediastinum. Classically, you can get like a really large aortic arch here. It has like a weird shape to it. Yeah, or just in general, like a widened mediastinum. For an ultrasound of the abdominal aorta, you'll see, you'll get this like a really large aorta shape. I don't know how to describe that any better. It'll be more than 3 centimeters. There you go. And then in terms of a dissection, you can get some really wonky pictures. So like in this one, obviously the white shows like a higher density. So that would be blood. So you've got blood that's like leaking out into the, like past the intima. And then on a CT, you can literally see this here is like the flap between like, this would probably be the true lumen. This would be the false lumen, I think, early days. I guess it's kind of a gamble. But anyways, this is like that flap in between the two lumens. In terms of management, what you do, so an aneurysm, you would generally try to do conservative. However, if these are true, then you would go to surgery. So if it's really large, like greater than 5.5 centimeters in a male or greater than 5 in a female, or if the person's symptomatic, right? Like if they're getting abdominal pain out of it, you definitely want to treat it. But otherwise, the conservative is just like blood pressure and lifestyle management. It probably won't go away on its own, so you just have to keep monitoring it via ultrasound usually. Otherwise, you can do fun stents and surgeries and grafts and all that cool stuff. And then for a dissection in terms of the management, obviously it's super urgent, chopper them to hospital. What you do first is you give them an IV beta blocker to slow the heart rate so that less blood is going into that dissected area. And then you give them GTN to vasodilate so that they can still get perfusion of the rest of their body in the meantime. The key is to do that after you've given them the beta blocker. And yeah, you aim a blood pressure of about 100 and do your graft repair. They also have these different classifications. It's probably not examinable, but if you're interested, they are there. All right, so next up is hypertension. Cool. So let's just go over the actual like physiology of why we have a blood pressure. So as you can remember, the carotid sinus has these baroreceptors. The aortic arch also has some baroreceptors, and they feed into the brainstem. So specifically that like medullary cardiovascular center. Then that ends up sending out your sympathetic and vagal responses to alter your heart rate, and then from the sympathetic perspective to cause your vasoconstriction. And just as a reminder, we have our mean applied pressure is made up of our cardiovascular output, and total peripheral resistance, right? And then your CO, so your cardiac output, is your heart rate times stroke volume. So putting that all together, this is how we have blood pressure. And then if you want to remember the other way of calculating a mean arterial pressure, it's your diastolic plus 1/3 of the pulse pressure. And the pulse pressure is the difference between systolic and diastolic. Great. And yes, I think that's kind of the important parts. I suppose the other part that we should talk about is when you get that SNS activation, it acts on your adrenals. And from there, you get your RAS system activation. So maybe we'll talk about that next. So in terms of the RAS system, let's go over the different parts of it. So you have the liver, which produces angiotensinogen, which then goes into the bloodstream. And then you have renin, which is produced by the kidneys, which converts angiotensinogen into angiotensin 1. Then you have ACE, which is an enzyme produced by the lungs, which then converts angiotensin 1 into Ang2. And then Ang2 is that active agent, which then goes on to stimulate the adrenals to release aldosterone, and then stimulates as well blood vessels to constrict. And then furthermore, that aldosterone itself causes that sodium reabsorption from the kidneys, which draws water back in to help increase your blood pressure. So the whole point of the RAS system is to increase blood pressure. All right. In terms of cause of hypertension, you guys probably know most of these. So as we age, our blood vessels become less compliant, so they can become stiffer, and then they aren't able to handle like the relaxation needed when we have an increased cardiovascular output. So that stiffening causes hypertension. Alcohol, salt, stress, poor exercise, genes, obesity, all that sort of thing. And then we have secondary hypertension. And a reminder that this type of hypertension that is from some other like physiological cause underneath. So most common in Australia is due to kidney disease, CKD, can also be due to OSA, and then endocrine things, so like adrenal problems, like your pheochromocytoma, thyroid problems, more likely hyperthyroidism, medications. So the way that we determine whether or not someone needs to go on blood pressure medication isn't just based off of their blood pressure itself, but it's based off of their cardiovascular risk. Same thing for when we were talking about lipids earlier. The way that you determine whether or not someone actually needs to go on lipid-lowering medications is based off of their cardiovascular risk. So let's go through what's actually like part of it. So the way that you do the screening is based off of age and other like comorbidities, or if someone is Aboriginal or Torres Strait Islander. So you go based off of that. And then the next part is that you put in all these different like variables. So like you'll put in their age, their systolic blood pressure, if they're on any meds, all that kind of stuff, if they smoke, and then if they have any other factors that you need to include, if they're diabetic, mostly these ones. Cool thing is it also includes their postcode now. So that's a good marker of socioeconomic status, which they found to be actually quite relevant. All right. And then based off that, it'll spit out to you their risk category. So high is greater than 10%, intermediate's 5 to 10, and low is less than 5. Some of the old guidelines go 5, 10, 15. But now you'll notice that high is 10 and up. So it's gotten like a bit more, like it's shifted a little bit. And then you reclassify people based off of if they have any of these other factors. I'll touch on a coronary artery calcium scores in a minute. And then, yeah, you're supposed to communicate their risk using these little diagrams, that kind of thing. And then we get to the management of their risk. So for people that are in that high category of greater than 10% risk, it's recommended that you prescribe them at least one of the two. Generally, you're going to prescribe both a blood pressure lowering and a lipid. If they're at that intermediate risk, then you're going to consider maybe you'll prescribe, depending on how their blood pressure and lipid levels actually are. And then if they're low, generally not needed. You can just stick with like your lifestyle modification stuff. So in general, for a standard patient, the target is less than 140 on 90. And for someone with cardiovascular disease, then you want or high levels of cardiovascular disease risk, you want their target to be less than 130 on 80. So like diabetics, for example. All right, in terms of medications for blood pressure, these are all first line. So since they have different contraindications, side effects, that sort of thing, what you're going to use depends on the patient. And the other big tip for blood pressure medications is that you start one agent, And you put up to like a medium dose. And then if you're finding you're not getting a huge success off of that, usually add a second agent rather than increase the dose further. So you'll often get those like combination pills for blood pressure medications. All right, so class-wise, we have our ACE inhibitors. So those are the ones that all end in pril. And the way that they work is they cause vasodilation because they actually reduce the amount of Ang2 that you have. And we know that Ang2 is a vasoconstrictor. They're contraindicated in pregnancy and renal artery stenosis because then that can cause you to go into an AKI. And the most common side effect for this one is a bradykinin cough. For the angiotensin receptor blockers, or ARBs, they have the suffix sartan, and they work basically the same way. So they have the same contraindications, makes sense. And the only thing you'll really see with those is like hyperkalemia. So personally, when I was on GP, that was what I'd go to as a first line because the side effect profile is pretty minimal and they're not going to get that bradykinin cough. So like, why bother putting people on an ACE inhibitor when they have that risk of bradykinin cough when you could just go right to an ARB? Like, makes sense to me. And they've got the same like benefit in terms of like stroke risk, like all those other benefits are pretty similar. And then the next line is your DHP calcium channel blockers. So those are the dipene ones. So those are your peripherally acting because they will vasodilate by relaxing like your smooth muscle. So these ones will commonly cause peripheral edema. So if someone has like heart failure, for example, and they have pretty bad peripheral edema or like severe lymphedema to start with, you're not going to prescribe these. And then the other one you can use are thiazides, so like hydrochlorothiazide or indapamide. These ones will act on the distal convoluted tubule in the nephron to reduce your sodium reabsorption, and then therefore you have less fluid getting drawn back into the bloodstream as well. Because of this, these ones you do not want to be using in gout and diabetes because the actual like mechanism for how they work is quite related to like the kidneys. Thiazides can also increase your blood sugars slightly, which is why you don't want to use it in diabetes. And they can mostly just cause your like electrolyte disturbances that I have listed there. And interestingly, they can cause impotence. So I think they like to ask that one as an exam question quite frequently. I didn't know what angioedema was. So that's something that you can get when you have like ACE inhibitors. Basically just a really bad swelling around your face. You'll commonly get these like really like puffed up lips and that sort of thing, just because you're getting edema in like the subcutaneous layer of, yeah. These are all of your second line agents. I think the important things are the things that I've highlighted in pink here about like when you shouldn't be using them. I think basically from everything below alpha blockers aren't really commonly used anyways, but I would say know when to use beta blockers and the potassium sparing diuretics. And of course, don't forget the triple whammy effect. So triple whammy is an ACE inhibitor, a diuretic, and an NSAID. So just a revision of how that actually works. So the ACE inhibitor causes dilation of the efferent. So that's the going away vessel, which causes like lowering pressure in the glomerulus itself. And then NSAIDs cause constriction of the afferent. So again, contributing to low blood pressure in the glomerulus. And then diuretics reduce plasma volume by getting rid of all of that. So basically, you're going to have like no filtrate if you combine all these together. Yes. All right, let's talk about secondary hypertension. So we talked about some of the causes. This is one of the other acronyms you can use, CHAPS. So Cushing's, hyperaldosteronism, so that's like a Collins tumor, aortic coarctation, that can cause secondary pheochromocytoma. So that's when you're getting like extra SNS activation, essentially, because you're getting cortisol released spontaneously from the sorry, not cortisol, noradrenaline released spontaneously from the adrenals, and stenosis of the renal arteries because the kidneys aren't being able to do their job properly because obviously they need to filter your filtrate. So some red flags for when to suspect secondary hypertension. Young people should not have high blood pressure unless they have significant metabolic comorbidities. So suspect secondary. If they're resistant to multiple medications, it's probably another cause. If they have unexpected end organ damage or unexplained other symptoms, like again, if you think about all of these, they're probably going to have a couple other symptoms related to that condition itself. Great. Moving on to pulmonary hypertension. This is basically the same thing as cor pulmonale, by the way. I'll talk about that in a minute. So let's talk about what pulmonary hypertension actually is, because I feel like we never really talk about it as a condition itself. But essentially, when you have damage to the lungs, then it makes it harder for the vessels to then perfuse the lungs because they're like become more fibrotic, and you'll get like thickening of the actual vessels themselves. And again, blood flow isn't able to cross through the capillaries as well for like your exchange. All those sorts of things cause increased blood pressure actually in the pulmonary vessels. That can then cause backflow into the right ventricle and then into the right atrium, because obviously from this pressure, like back up. The actual causes are like through this classification scale of 1, 2, 3, 4, 5. One's idiopathic and heritable. 2 is caused by left heart disease, right? So we know that if you have left heart failure, you're going to get the blood backing up into your lungs, and then therefore you can get that back up even further into the right side of the heart. We know that lung disease, that's the #1 cause in Australia. Pulmonary artery obstruction, like if you had some like chronic PEs, which is weird. And then other, I'm not sure what that would be. So cor pulmonale is exactly what I was talking about. It's like right-sided heart failure generally caused due to the lungs, right? Like cor for heart, pulmonale for lungs. So usually it's caused by COPD. And you start to get some more of those like greater systemic problems. So like when you have the blood that starts pooling in the right ventricle and then the right aorta, the next place that it's going to go is up to the JVP because you don't have any valves within the JVP to prevent backflow. So it'll go back up the JVP. And then similarly, you'll get hepatomegaly because you'll have the backflow down the IVC as well. In terms of how you make a diagnosis, the technical way to do it is by doing something called right ventricular catheterization. So they'll do like this invasive procedure to basically put a probe into the pulmonary vessels and then measure what the pressure is. So if the pressure is greater than 20, that's classified as being increased pulmonary pressure, so pulmonary hypertension. More practically, though, you can diagnose it based off of an echo. So you'd see like here, there's a very large right ventricle. I think this is at a point in contraction, which is why the left ventricle is quite small. But you can see that like that right ventricle is quite large, or it might just be the angle of it. And then in terms of a chest X-ray, you can see some dilated pulmonary vessels. So like you can see some on the side here, and then some kind of like tucked behind that bit of the heart there. And then you should theoretically see like a dilated right ventricle. So like this would be the right ventricle. It looks a little bit wide, like on this portion here. So this was that catheterization I was talking about. So it's a percutaneous intervention. You can go in any of these spots, and then you literally go right up through the right atrium, right ventricle into the pulmonary vessels to measure the blood pressure. And you're looking for a mean pulmonary artery pressure. In terms of what you actually do about it, this is a cardiac problem. So you refer to a cardiologist. They're probably already going to be seeing a respiratory physician as well for their COPD, I would assume, because that's most likely cause. And you just treat the underlying cause. You can use some of these fancy drugs, but those are all cardiologist managed anyways. So it's not managed with all the same drugs that you would use for like left-sided heart failure. Cool. Next up is varicose veins and chronic venous insufficiency. So let's talk about what actually happens with these. So we know that we have our valves in veins that help prevent backflow, but the problem is varicose veins is what you get all this blood that starts pooling because of these things like obesity, pregnancy, family history, and long standing. So then it actually starts disrupting the valves themselves, and then they don't close properly. So then the blood pools even more so, and then you start to get the blood pooling in such a way that it causes these like curly, bulging veins. The main problem with these is that when you have blood that's pooling and sitting and the flow is all disrupted, you're obviously at risk of clots. So in terms of like chronic venous insufficiency, these are the buzzwords for it. So hemosiderin staining, so that's like this brown kind of staining. That's because when you get the blood pooling, some of it will undergo some breakdown. We know that broken down blood cells have this kind of like hemosiderin staining from the iron that's actually in them, like the heme. Then you get something called lipodermatosclerosis. That's this like champagne bottle leg. It's the same thing here. So you get this kind of like a weird shape where you get like some like a tightening of the skin over this lower area and then like a ballooning above that area. I'm sorry, I don't have a more technical way of describing that. There's also a term called atrophy blanche, which are these little like white patches that you can get on the leg. And then they'll be quite itchy. That's the other thing. In terms of the diagnosis, what you do is mostly history and exam. They have something called the SEEP classification, which is these 5 to 6 stages here. So on exam, you can see like what degree of varicose veins up to like a venous ulcer that they have. So again, minor to mild, minor to severe. Sorry. The other way that you can do the diagnosis for this is to do a compression ultrasound to rule out a DVT or like an SVT. So if you haven't actually seen these done before, what they do is they literally just put like the probe, which would be up at the top here somewhere, and push down on a vein. So like normally you'd expect a vein to be able to collapse, but if it has a clot in it, it will not be able to collapse. So this is not for varicose veins, but this is if they have like a clot in them. So this is just something that you do to rule out, because that would be like your other differential for like a swollen leg, kind of like how you can get that in like more edematous types of chronic venous insufficiency. So the lifestyle management for varicose veins is really the mainstay of it. So you want to do things that are going to return your venous return. So calf pump exercises, elevating the legs, compression stockings, and then just triggering your tackling your risk factors. You can also do things like thermoablation and sclerotherapy, which basically cause the vein to constrict. So it will like collapse the vein onto itself. And that can help so that you don't get like that bulging. And the main reason that you do that is, as I mentioned, like you can get an SVT by having those veins that have this pooling blood. Obviously, if you collapse the vein, then the blood flow will have to use deeper veins to be able to return. But that's kind of how what they do. And you can do a vein valvuloplasty, so that's just like a repair of the actual valves within the vein itself. So as I mentioned, your main complication to keep an eye out for with varicose veins is that you can get more likely superficial venous thrombosis, but the problem with this is that it can progress to a DVT. So you want to stay on top of it. So depending on the location of an SVT, it determines what you do in terms of management. So you can like follow this flow chart, but I won't focus on that now. Okay, so the next station or the next topic is vascular injury, which I think is weirdly broad to be on like the matrix. So let's just talk about like how vessels actually heal. So the first part is you get vessels will constrict when they have damage because they're trying to obviously stop the loss of blood. So you'll get constriction as the first stage. Then secondary stage is that you get this primary hemostasis. So you know that you have that platelet activation, which causes that clot formation. And then the secondary part is that you get a fibrin clot that replaces that. So they have something that they call the hard signs and the subtle signs with vascular injury to basically determine how severe it is. So like your hard signs are active hemorrhage, absent pulses or ischemia, expanding of pulsatile hematoma, right? Like if you have like a pool of blood and you can feel it pulsating, like that's probably a vascular problem rather than just like some degree of hematoma. Bruit or thrill, right? Because that's disturbed blood flow. And then those like subtle signs are like a slightly reduced pulse or hematoma, but not pulsatile, that kind of thing. So then like the management that you'd be using in terms of vascular injuries, it really depends on like what the signs are. So if you're having those hard signs that I've mentioned earlier, you're going to see if the person's stable or unstable. If they're unstable, obviously like you have to take them into the theater and stop the bleeder. If they are stable though, then you want to see like what is actually going on. So you have more time to do imaging. And with those like soft signs, you'd follow this pathway. The other thing is like for late presentations of someone that has a vascular injury, you're going to be concerned more if it like needs to be amputated, like if it's gotten to that more necrotic stage from not having enough blood perfusion. All right, so next up is diseases of the heart valves. Most of these heart murmur slides were recycled from Madeline's slides, so thank you in advance to her. So first, let's go over where we actually auscultate for the different valves. You can use the all patients take medicine mnemonic, so A for aortic, P for pulmonic, T for tricuspid, and M for mitral. The good way, like, or my favorite way to think about this is which valves are inside versus outside, or she's written them as left side valves versus right sided valves. So the left versus right is relative to the actual like heart's anatomy itself, and the inside versus outside is relative to where you actually auscultate them. So when I'm talking about this inside versus outside thing, I mean that the inside ones are these ones circled in red here. So that would be your pulmonic and tricuspid. And I use this to remember which ones are louder on inspiration or expiration. So these ones are the inside ones. So the murmurs there are going to sound louder on inspiration. And the outside ones are aortic and mitral. They're going to sound louder on expiration. And if you think about the actual like pressure changes that happen during breathing, for the inspiration ones, as you're breathing in, the pressure in the thoracic cavity is decreasing so that you can get air into the lungs, right? So when that pressure is decreasing, it's going to promote filling of the heart. So that's why you get louder sounds from the pulmonic and tricuspid, because those are the AV valves, right? So more blood is going to be going into the atria, versus the aortic and mitral sounds are going to be, or murmurs are going to be louder on expiration usually, because you're increasing thoracic pressure. So it's helping to like push the blood out of those valves into the rest of the body spaces. So that pushing is going to be causing them to be louder. I hope that helps. Okay, so you've got two different types of valves. You've got your semilunars and you've got your AV valves. All the valves are tricuspid, or sorry, have three, well, yeah, I guess tricuspid, have three cusps, except for the mitral valve, which is bicuspid, it has two. If for any of the other valves you see that they are bicuspid, you know that that's like a like congenital abnormality or some like sort of change that's happened to the valve. So sometimes you'll see that with aortic, I believe. Um, I think that covers most of the important things here. I guess the other thing to keep a note is that the bicuspid valves have anterior septal and posterior leaflets versus the other ones that have three cusps are left, right, and anterior. So the names are a little bit different, but I think that'd be a main MCQ. Anyways, just going back to the basic physiology. So we know that during diastole, that's when you have filling of the heart, and then systole is when you have like your ventricular contraction so that you can get all the blood out. So that's how you get your like lub-dub type sounds. And the different valves are open at different points depending on like the pressure gradients and where the blood flow is meant to be going at that point. I'll leave this up so you guys can go through it on your own time if you'd like. I think what I will spend a bit more time on is understanding the whole concept of like what an S3 sound is, because if you can remember why it happens, it helps to remember what conditions you might hear it in. So generally S3 is coming from when you get blood flow coming into the left ventricle that actually hits like the wall of the left ventricle in early filling. So that's something that you might see in ventricular dilation, because you have like a larger part of that ventricle for the blood to come in and essentially hit to make that sound. So it always occurs after S2, and it'll sound classically like the Kentucky, Kentucky, Kentucky. Sometimes it's called like a galloping sound. So if you think about what conditions can cause a dilated left ventricle, it's usually heart failure and then mitral regurg. So similar S4, this is like the opposite sort of situation where you have thickening and stiffening of the left ventricle, so that the sound that you hear is still blood hitting the left ventricle, but now it's because the ventricle is like too stiff. So this will be an early sound, so it comes before S1, and this one sounds like Tennessee, Tennessee, if you can actually hear that with the stethoscope. I don't know anyone who actually can, but we'll pretend. And then if you think about what conditions cause like that enlargement and thickening of the heart wall, the most common or like the most prominent one to actually give you an S4 is hypertrophy. All right. Next up, I really hated the JVP until I understood that essentially it's just mirroring the pressure of the right atrium. So if you can think about what the right atrial pressure will be, you can generally figure out how high that wave is. There's some nice little lettering on the side here, so you can get an idea of like how to remember them. But essentially the A wave is during atrial contraction. So that's when you're going to have your highest pressure, obviously, because it's contracting to get all the blood out. And then it starts coming back down because you're losing all that blood. So again, like the JVP, blood is going to come down. And then the next phase is going to be your V. So that's when all the blood is filling into the right atrium. So at that point, pressure is slowly rising again. And then Y is when you start to get the valves opening to empty the atrium, but it hasn't quite had that contraction. So that's why you get a slight decrease, because a little bit of blood's going to come out when the valves open. And then, of course, we go back up to A when you get that contraction. So I guess another good way to remember this is thinking about like what causes all those different changes. So anything that causes an increased right atrial pressure, so like right heart failure, excess fluid, that sort of thing is going to cause a raised JVP overall, and in particular, you're more likely to be able to see like increased A waves. I think that's probably the most common time where you're going to be asked about JVP is just like a raised JVP. So you guys should know that one. That's like your bread and butter for heart failure. Okay. Here are some other tips that Madeline had included for like understanding murmurs in general. I think some of these are actually quite helpful. Generally, you want to be thinking about the heart valve that you're auscultating at any given point. Whether the sound is heard in diastole or systole is a massive help to you, because if you can figure out whether that valve is open or closed, then you know what kind of murmur it's going to be. So if it's a problem with a heart valve that's closed, it means it's regurgitation, right? Like it's meant to be closed, but instead you're getting sound through it because the blood is doing that backflow. And the opposite, if you're hearing sound over a valve that's meant to be open, it's more likely that there's stenosis, right? That's where you get that like noisy sound from the blood actually trying to go through, but there's not enough room. The next point that I think is pretty good, if something is stenosis in systole, it'll be the opposite in diastole. So that's like that example there. The next bit is to remember like which pairs of valves go together. So if you can remember, like the AV valves will always be together. So that's like your mitral and tricuspid, and the aortic and pulmonary will always be together. So those are your semilunars. So if there's stenosis in one, that would be if there's stenosis in one of those in diastole, there'd be stenosis in the other one in diastole if it was like a stenotic vessel problem. Hope that made sense. And then this is another good tip. So if there is a displaced apex beat, so again, displaced apex beat just means that it's over further, like more laterally in the heart than it's meant to be. That's just because you're having dilation and hypertrophy of the heart. So in that case, it's always going to be due to some sort of like regurgitation problem or like heart failure problem. That's what also like regurgitation really is what causes that like dilation and hypertrophy. So it's not going to be a stenosis problem. All right, cool. If you want to go through this, these are just like the different actual like sound patterns. Some of them are kind of like buzzwordy, but I'll go through them like as we go along. And then this is just like your list of which ones you're going to see in systole, and then which ones you're going to see in diastole. I'm going to try to focus my emphasis more on the common ones. So those are the ones that are in bold here and here. Cool. So aortic stenosis, this is your most common. It's really important to know. So this one, I think something that helps remember is it's the crescendo decrescendo. Not many of the other ones are crescendo decrescendo. So considering this is also like most common, if you see crescendo decrescendo, most likely is going to be aortic stenosis. This one also classically radiates to the carotids, and it's louder on expiration because remember, aortic is one of those outside valves. So you can get a bicuspid valve, which contributes to aortic stenosis. And the like changes that you can see in like a bicuspid valve that's undergone some degeneration is like classically seen as its fish mouth appearance. That's what that image is there if you're wondering what was going on. But yeah, this is a common disease due to calcification over time. So older populations, it's more common. And it will be symptomatic. So the classic acronym is SAD backwards in terms of like the chronicity of what symptoms you're going to get. So first will be dyspnea, second will be angina, and third will be syncope because you're literally not getting enough blood supplying the rest of the body because of the aortic stenosis. And as you can remember, the filling of the coronary arteries happens just at the like the base of the aortic valve. So if you're not getting enough blood flow through the aortic valve, then you're not going to be getting enough actually filling the coronary arteries, which is why you get the angina. Cool. Yes, I think I said most of this already. The biggest thing for this one is you might confuse it with a Hockham type sound. So that's like your hypertrophic obstructive cardiomyopathy, because that one you can also get a similar murmur in the aortic region. The difference is it will not change when you do a Valsalva maneuver, right? And Valsalva is like classic, like increase your pressure, like blowing your nose while holding it, that sort of thing. Aortic sclerosis is just early aortic stenosis. That's probably all you need to know about that. Don't worry about pulmonary stenosis. Mitral regurg, you should know. So this is the second most common murmur. And the classic presentation for this one is you'll hear it over the mitral valve. So like or sometimes they'll say like at the apex of the heart, and it will radiate to the left axilla. And it's louder when you're laying on your left side because you're increasing the pressure down over the mitral valve, and louder with expiration because it is one of those outside valves. You can get mitral valve prolapse, which causes mitral regurg. That one, like most commonly, has like a click sound in it. So prolapse often does have like that click. Otherwise, in terms of like etiology for these ones, common ones are rheumatic heart disease and infective endocarditis. So keep those in mind. Cool. There's just a picture of like what prolapse actually looks like. So like the valve will like dig deeper into the left ventricle. Yeah, I think that's good to know. And again, this is something that you can get that S3 gallop, so like that S3 sound, because you have the dilation of the left ventricle. You can also get a displaced apex beat from this one. Cool. Tricuspid regurg. This one is more useful to remember just because you can get it with like IV drug users that have infective endocarditis. They're going to have damage to the tricuspid valve causing regurgitation. We'll go over that in a little bit later. Because of this, you're going to get backflow, causing all of like your right heart failure symptoms, so like pulsatile liver, and elevated GVP, specifically the V wave. Okay, so HOCM, this is that hypertrophic cardiomyopathy, and the O is for obstructive, so sorry, hypertrophic obstructive cardiomyopathy. So what happens is basically when the ventricle constricts, you're getting like this part of this thickened septum actually like blocking your blood outflow. So if you can imagine, you block that blood outflow to the through the aorta, someone's not getting any cardiovascular like blood flow to their brain during a contraction as they normally should. So you get a sudden collapse. Otherwise, it'll be like in a healthy person. And this one is on Valsalva because as you can imagine, like if you increase the pressure, then the valve is going to like the heart's going to squeeze even more so. So you're more likely to trigger it. All right. So aortic regurg, this one is also good to know. This one is weird because you actually hear it over the pulmonary area. So just remember that the pulmonary murmur is actually quite uncommon, like pulmonary regurg or pulmonary stenosis are quite uncommon. So if you hear something over the pulmonary, it's actually more likely to be aortic regurg. Again, this one you can have it due to infective endocarditis and rheumatic heart disease. Say that's the important stuff for that one. Yes, the other important thing for this one is the water hammer pulse. So what happens with this, as you can imagine, like blood's going up through like the aorta, and then since it's regurgitating back down the aorta, you get a strong pulse that then quickly drops off because the blood's coming back out. So it'll be like this water hammer shape, as you can see on the image there. You'll also get a wide pulse pressure for a similar sort of reason because the blood pressure during systole is going to be very high, but then as the blood is coming back down during like that early diastole, the blood pressure is going to be lower because it won't have that continuation during the pulse. Yeah, pulmonary regurg, I don't think you really need to know about that one. Mitral stenosis, you do. So this one will be a rumbling murmur is what they like to call it. And again, it's louder on the left lateral position, so a little bit confusing, but mitral regurg is more common epidemiologically. So if you had to pick one, that's probably a good one to go with. Otherwise, yeah, also can be caused by rheumatic heart disease. So you're noticing a bit of a trend here. What you can get with mitral stenosis is this like classic mitral phases. That's like that pinking of the cheeks. Um, I think that's about it for mitral stenosis. Yeah, don't worry about that one. Cool. So here's just a nice little cheat sheet chart for the different ones if you're trying to differentiate between them. I would say this is probably pretty useful, especially when you're talking about the inspiration, expiration, if you're confused about that, and the Valsalva, because they like to use that one as like a keyword. But generally, if it's louder on Valsalva, it's almost always going to be HOCM. Cool. In terms of the other murmurs, I think the other key one to know is this flow murmur. They like to ask questions about that one. The reason you get a flow murmur is just from increased blood turbulence going through the heart. So if you have just like literally more blood in in each pulse, then you're going to have a flow murmur. So it's seen in things like pregnancy because your blood volume just increases. Or it can be seen, the classic is like a person that collapses at a party, usually because their heart rate is increased either from using drugs or from like dancing and that kind of thing. Or you might see it in like someone with anemia because to compensate for the like lower hemoglobin actually carrying the blood, usually you'll have uh like a larger blood volume to help compensate, or you'll have like a quicker pulse to help compensate for that. All right. Ultimately, to diagnose an echo, or sorry, to diagnose a murmur is you do an echo. That way you can actually see how much blood is going through each valve, if there's any blood going like backflowing through the valve, if there's any structural problems. So if you have a murmur, get an echo and refer to a cardiologist. Really, the management of murmurs is treat the underlying cause where possible, but ultimately, if they have some sort of problem with the valve, you have to just replace the valve, right? Like you've got to fix it. So for valve replacement, you've got two different options. You have mechanical valves, which are great for young people because they last for a very long time. But they need lifelong anticoagulation, which is not ideal. So you're going to aim for an INR of like 2 to 3, or some guidelines say 2.5 to 3.5, but around there, using warfarin. The bioprosthetic valves are good because you don't need to anticoagulate as long. It's only 3 months, but they don't last quite as long. If you do want some practice to listening to murmurs, this is your go-to. All right. So next we're going to talk about rheumatic fever because this is also very much on the theme of valves. So what rheumatic fever actually is, so you'll get this like inflammatory process going on that it can involve essentially everything in the body. It happens a couple weeks after getting a group A streptococcus infection, so GAS infection. Classically, we talk about using the Jones criteria, so that's what that image is there, and we'll go through it a little bit more. So group A strep, strep is gram-positive bacteria. Often they'll make these little chains, right? So you get those little orangey chains. Sometimes it looks like a string of pearls on microscopy. And they're group A, so that's the beta hemolytic strep. The like conditions that you'll actually get group A strep in will be like tonsillitis and pharyngitis. So often they'll be like someone has a sore throat with like white exudate to be like it's some sort of bacterial tonsillitis. Or it can be impetigo. So that's this one. That's where you get these like classic honey crusted lesions. The other two conditions are scarlet fever and post-strep glomerulonephritis are the kind of like keys that, hey, there might be some group A strep. Group A strep going on here. In terms of the actual pathophys of what happens, so first you have that infection with group A strep, let's say like tonsillitis, pharyngitis, or impetigo usually. And then from there, your body makes anti-strep antibodies against the M protein, which is part of the bacteria, I suppose. And they get released into your system. And then it's actually the antibodies which cause problems. So they like have this like they call it molecular mimicry. So basically they resemble something which allows them to cause like an inflammatory response throughout the entire body. It's a type 2 hypersensitivity. Immunology is not my strong suit, so I might just leave it at that for simplicity. But the important thing to know is it's not actually the bacteria that cause the problem. It's the fact that you have an immune response against it. And then those antibodies are what's actually causing the problem. So the people at risk for this, for rheumatic fever, are people that are at risk for group A strep, right? So anyone that is Aboriginal, particularly living in rural or remote housing or in crowded housing, but that applies to anyone in general living in crowded housing. People that have like a personal history or family history of rheumatic fever, rheumatic heart disease, and then the classic regions that have a high epidemiology are far north Queensland, the NT, the Kimberley, and the Pilbara regions, and also refugees and migrants. Unfortunately, rheumatic fever is much more common in people that are young, so usually like 5 to 20-year-old. So high risk is generally under 40. All right, so the way that it presents actual rheumatic fever now, so you get all your classic like malaise symptoms. You get migratory polyarthritis, that's like painful joint, but then it can spread to other joints in kind of like a random fashion. You get chest pain because they can often get pancarditis. So that's like endocarditis, myocarditis, and pericarditis. They get valvular lesions, so you'll hear a new murmur often. And then they'll get Sydenham chorea. I've got a video linked there, but essentially it's like these weird jerky movements that kind of look like a seizure, except for they're not like rhythmic. They're just kind of random movements. And that's due to damage to the basal ganglia, right? So all of your like dopamine receptors, which cause like your normal cohesive movements. So it almost has like kind of like a Huntington's type presentation to it. And then you'll get this rash. This is called erythema marginatum because it's got those like clear or like those reddish margins to them. And then you can get these like subcutaneous nodules. So those are all kind of the symptoms of the presentation of rheumatic fever. And as I said, that's like 2 to 4 weeks after having the group A strep. So in terms of like how you diagnose it, you do your workup, so FB, CRP, ESR, because you're most likely thinking this is going to be some sort of infection. You want to do blood cultures, see if they're septic. And then you would do the anti-strepsilicin O titer, so that's for the antibodies, or you can do an anti-DNase B titer. So two different options, but I think the top one is usually more common. And then you want to be figuring out like where the infection's coming from. So usually you do a throat swab and send that off for microscopy, culture, and sensitivity to see if it's growing group A strep. If they have like a joint that's very painful, you have to rule out septic arthritis. So you might need to do a joint aspirate. On ECG, you can see PR prolongation. There was some thought that like you get that because of an increased vagal tone, but we won't worry about that. But ultimately, you want to do an echo to make sure that they don't have any rheumatic heart disease. So most likely it's going to be affecting the mitral valve, usually causing regurgitation, or it can also cause aortic regurgitation. And then later on, you can get stenosis of those valves. Because what happens initially is you get inflammation of the valves so that they don't close properly. And then that becomes like fibrotic and stenotic as time goes on. Which is what causes the stenosis, like later stages. So in terms of the actual Jones criteria for making your definitive diagnosis, I think this is pretty important to know. You need two things. First, you need to confirm that they've had some group A strep infection. So that's doing your titers or having like a positive throat culture, or you could even do a rat test for GAS. So that's the first part, is you need proof that they had GS infection. And then second is based off of the symptoms. So you need 2 of the 5 major criteria, and these are supposed to spell Jones, although the O is supposed to be like a heart for carditis. So J is for joint pain, O is for carditis, N is for nodules, like those are the skin nodules you can see. E is for erythema marginatum, and S is for Sydenham chorea. If you've got 2 of those, plus the GAS infection confirmed, then you've got rheumatic fever. Or you can have 1 major and 2 minor criteria. So the minor criteria are based off of, it depends if someone's low risk or high risk, what the cutoffs are. So if I have in brackets LR, that's the low risk cutoff, and HR is the high risk cutoff. So I had those high risk factors a couple slides back. I think that's probably a bit too detailed, but generally you need to know if they have a fever, a prolonged PR interval, joint pain, CRP elevated, and an ESR elevated. So if they had 2 of those plus 1 major, that is also your criteria. All right, in terms of management, what you do, it's benzylpenicillin intramuscularly, and it's also done by weight. So it's a simple dose, it's a long acting, and that should help treat the actual GAS infection. It doesn't actually treat rheumatic fever, but it treats the infection. So the second part they do is to treat the symptoms. So give them like naproxen. If they have a fever, you can paracetamol, all that kind of stuff. And then going forwards for like long-term management, you have to do echoes to see what their heart function is like and if they're having any heart disease as like a secondary to it. Unfortunately, people also need to get these benzylpenicillin injections for quite a long period of time after having rheumatic fever, because people at risk of having rheumatic fever, like unless their entire life like changes, they're unlikely to get away from having those risk factors. So they need to stay on the prophylactic antibiotics, which is really unfortunate because if you think about it, a lot of these people are kids, right? So it's like a kid having to go get an injection every like 3 to 4 weeks from it's minimum 1 year, but it can be up to lifelong depending on like all these different criteria. So if you want to look at the criteria, you can click on that link there. And then ultimately, if they did have rheumatic heart disease, to the point that they're very symptomatic, you might need to do a valve replacement, and put them on heart failure management. But hopefully it does not get to that stage. Awesome. On the topic of bugs and the heart, next up is infective endocarditis. So infective endocarditis is when you have bacteria that are in the bloodstream, which then cause inflammation of the endocardium. So therefore the heart valves, because they're like a continuation of the endocardium, right? So you got these like bacterial growths on the sides of the leaflets. So then the valve doesn't close properly, hence why you get a new murmur. So it happens either acutely, so from like days to weeks, or you can have subacute endocarditis, which can be from like weeks to months. Um, yes. In terms of the risk factors, older people, people that have a cardiac history, so any sort of like damaged valves or replaced valves are more likely for the bacteria to like want to latch on and grow onto them. People that have like pacemakers in because the pacemaker leads are essentially a foreign body, they're more at risk. IV drug users because they're more likely to be putting bugs into their blood. People with poor dental health, because if you think about it, if you had some sort of dental infection, it's a very small pathway from having decay in a tooth into going into the bloodstream, and then that can go down into your system. And then anyone that has an IV device. And unfortunately, also people that get like any sort of like hospital procedure done, right? Because hospital acquired infections are rampant. So in terms of the heart valves that are actually affected, number one is your mitral valve. I think that's because it's a bicuspid valve. There's some extra risk due to the shape itself. Number two is the aortic valve. And then number three is the tricuspid. But like think about that. It's almost always pathognomonic with someone who has had an IV drug use history. And the reason for that is because it's the first heart valve that it's going to come, that the bloodstream is going to like come across as it's coming into the heart. So being that first one, it's most likely to be impacted. In terms of which pathogens are actually at fault, the most common is Staph aureus, which is really unfortunate because it can affect healthy valves. Like some of the bugs are more likely to just only affect damaged valves, but staph can ruin your like good valves. It's something that you will see more common in IV drug use just because it's your like epithelial flora. And it's going to be causing more likely acute infective endocarditis. Like it's a bad bug. 20% are Viridans strep. So that's like your different group, that's alpha hemolytic strep. So don't get that confused with group A strep, because that's beta hemolytic. So maybe just review your microbiology if you're a bit iffy on that. That's more common if in people that have like dental procedures because it actually lives in the oropharynx. And it's the most common cause for subacute infective endocarditis, but it's more likely to damage just like pre-damaged valves, like at-risk valves. You can also get staph epidermidis. And then in someone who's immunocompromised, you can get some really weird ones. You can get fungal infections, your gram-negative infections. That might also be dental. And then this really, really weird one, which for some reason is associated with colon cancer, which I find very odd. All right. In terms of actual symptoms of infective endocarditis, the most classic is like just general malaise, right? So fever, chills, night sweats, but you can't find some sort of like source for it. That's kind of like when you should be thinking, is this infective endocarditis? And screening for those risk factors. In terms of like cardiac symptoms they can get short of breath, fatigue, and dizziness because of the damage to the valves themselves. And then you need to be thinking about all the symptoms that can come up as a result of the septic emboli. So you can get septic emboli to the brain causing stroke, into the lungs causing hemoptysis. It's like essentially like a PE, but due to like a septic embolus. You get visual changes because they can lodge into the retinas. That's your classic Roth spot, says a buzzword. You can get them spreading into the hands. You get your splinter hemorrhages, Osler nodes, and Janeway lesions. And a reminder that the Osler nodes are the painful ones. Think Osler ow, so the little O's. Painful ones and the Janeway are not painful. You can get glomerulonephritis because it'll go into the septic emboli can shoot off into the glomeruli. And then you can also get arthralgia because you can have septic emboli going off into the joints. So a little side story. I had a patient that had was presumed to be admitted for septic arthritis. And then one day he started coughing up blood. And it was at that point that someone was like, hey, even though he's on ortho ward, let's listen to his heart and see what's going on. And they were like, hey, he's got a murmur. And at that point, he was diagnosed with infective endocarditis with having no risk factors when it was initially thought to be a septic joint. So you might actually see those septic emboli outcomes before you realize all the other stuff. Like he had subacute, so like he wasn't super, super unwell until like those later stages. All right. In terms of how you diagnose it, it's a new murmur plus a fever are like your two things as a go-to to be like this is infective endocarditis. Um, and then in terms of investigations, you always want to do your like inflammatory stuff, so FBE, CRP, ESR, and you want to take 3 sets of blood cultures, ideally from 3 different locations. So like one from one arm, one from another arm, one from another site. I don't know, pick your site. And then in terms of the diagnosis, you do an echo and you would be seeing these vegetations. So that's like the little red bits on top of the valve attached to them. So the criteria for diagnosis for infective endocarditis, so you can have the 2 major criteria, or you can have 1 major and 3 minor, or you can have 5 minor for like a definitive diagnosis. So your major are the blood culture and echo, and the minor are all of these ones here. So fever, some sort of like Osler nodes, rough spots, that sort of thing, positive blood culture, but not in that specific time frame, some evidence of emboli, and some sort of risk factor. Oh yes, and those are the Duke criteria, by the way. Cool. You might see different times where people have like vegetations on their leaflets, and it can be due to different causes. So let's just review those quickly. This is more relatable for path. So rheumatic heart disease, again, that's caused by strep pyogenes, which is your group A strep. So that's an antibody induced, and you'll see like the little vegetations all the way across the valve. Infective endocarditis, you'll get very large, chunky vegetations that are like eating into the valve. And again, that's due to actual bacteria in the blood. Don't worry about this one. The other one that's like a differential is in lupus or antiphospholipid syndrome. You can get Liebman-Sachs endocarditis. That's where you get these like kind of medium-sized vegetations, and they'll be on both sides of the valves, versus the other ones are usually just on one side of the valves. These will be on both usually. The management for infective endocarditis depends on if they have a native valve or prosthetic valve. The guidelines seem to be changing on this because, again, you have like all your different bugs, so it depends what it is to treat it. So if you had an OSCE station on this, always just say I would consult infectious diseases, or something like that. But it's always IV antibiotics for 4 to 6 weeks. If you have a native valve, you can use the mnemonic Big Friendly Giant for BFG. So that's benzyl penicillin to cover your gram positives, flucloxacillin, which has really good Staph aureus cover. And again, we know that's 40% of cases. And then gentamicin covers your gram negatives. If it's prosthetic valve, the mnemonic is very friendly giant, so VFG. So we've got vancomycin, and that covers better than benzyl penicillin because it has like more of your MRSA cover, and then you use the other two. Awesome. Moving on to myocardial disease. So the first one is heart failure. This is a big topic, so if you want a break, this might be a good time to do so. Shockingly, 10% of adults over the age of 65 have heart failure. So it's very common. And I think the important thing for us to do as doctors in the future is explain to patients that heart failure doesn't mean they're imminently dying. It just means their heart is not working optimally. Because heart failure sounds very, very scary. But if you let them know that 10% of their friends over 65 also have heart failure, that okay, maybe does sound scary, but that could also be a bit reassuring that, hey, this is not going to kill you this instant. All right, so in terms of the pathophys for heart failure, I think this can be kind of confusing, but we'll try our best. Usually it starts from having some sort of myocardial damage, or so that's like having an AMI in the past, or it starts from having some sort of problem with the resistance. So if you have high blood pressure chronically, the heart has to work very hard to pump against that high blood pressure. Similarly, if you have uh, too much blood volume, like from too much preload, then the heart has to do a lot of work and is always being stretched out extra far. So over time, that does cause some damage to the myocardium. But essentially, both of those sorts of things can cause decreased left ventricular function because the heart is tiring and it's not able to pump the blood as effectively. From that, you're going to get worsened cardiac output. So you start to see your blood pressure decreasing. And from there, because when your blood pressure decreases, your body panics, you're going to get your activation of your SNS, the RAS system, your AVP, so that's like your the fluid retention as well. And then you're going to get some other things that I don't really want to worry about too much. Um, Similarly, like your kidneys themselves will react to this, right? So when the kidneys notice that there's decreased blood pressure, they'll be hypoperfused. From that, they'll start to resorb sodium and then resorb water as well. So from that, you start to get your edema because now the person is fluid overloaded out of an attempt to try and increase the blood pressure. And then from that, you're going to get more congestion into the liver, the IVC, that sort of thing, which then causes increased preload, which then puts more strain on the heart. And it's like this vicious cycle that goes over and over and over again. Essentially, heart's not pumping well, blood pressure goes down, your body's doing everything as possible to bring the blood pressure up by the RAS system and the SNS system. Probably just worry about those two. From that, you have fluid retention, which causes further damage. So in terms of the actual like underlying causes, as I mentioned, the things that cause myocardial damage, so like having an AMI, having anemia where you're having like chronic ischemic processes going on in the heart, drugs, cardiomyopathies, autoimmune diseases, and then yes, chronic hypertension or chronic pulmonary hypertension. And then of course kidney disease. Ah, yes, and then we also have up here valve disease and arrhythmias. So lots of stuff. Um, I think the way that you need to understand heart failure is really based off of if it's HFrEF or HFpEF. So HFrEF is reduced ejection fraction. So that's less than 40% ejection fraction. And HFpEF is preserved ejection fraction over 50%. So your ejection fraction, keep this in mind, is the amount of blood that is in the heart during diastole. It's about how much of that is actually making it out of the heart during a contraction. So stroke volume over the end diastolic volume. So if your ventricle is totally full, but only half of it is going out, you'd have a 50% ejection fraction. All right. In terms of HFpEF, we'll talk about this one first because it's a little bit easier. HFpEF is caused by usually more like metabolic problems. So classically like diabetes and obesity is like part of the stem that you'll see for that. So this causes like hypertrophy of the left ventricle because it's trying to pump against all this like peripheral resistance. But it's not going to have, it's just due to poor filling of the left ventricle. So as we were talking about here, in HFpEF, you have this diastolic dysfunction. So often they'll call it like diastolic heart failure and call HFrEF systolic heart failure. So in HFpEF, the ventricles are so enlarged that blood's not entering into the ventricles. So you've got so little blood to squeeze out. So you'll actually have a preserved ejection fraction because it's squeezing the blood fine because you've got all this heart muscle, but not enough blood is in there in the first place. The opposite is true for HFrEF because you'll have these weak, dilated, sad heart ventricles, but they have tons of blood in them, but the blood is just like not going anywhere. Yes, and we just talked about that. All right, so in terms of how someone presents with heart failure, fatigue is the most common first symptom. You'll get dyspnea, so shortness of breath will be on exertion while laying down, so that's orthopnea, and paroxysmal nocturnal dyspnea, so waking up at night with that choking, coughing, can't breathe feeling. You'll get bilateral pitting edema, and again, you measure it along the tibial plateau, going from the medial malleolus and then all the way up the tibial plateau. And then if you're getting it at the knees, keep going up the legs. You can even do like on the sacral area as well. They might get a cough that will be like clear and frothy or sometimes with like a slight pink tinge because they have this, all the fluid in the lungs that's causing that cough. They might have right upper quadrant pain from the congestion in the liver. They can also get nausea from that. And they can also get nocturia because I don't have a great understanding of this, to be honest. However, my understanding is that when they're laying down at night, there's some changes in pressure that actually cause the kidneys to be able to process more of the fluid. So they actually lose some of that like fluid retention need. I think potentially also because like your SNS activation decreases, that sort of thing. Anyways, you can get nocturia. So their vital signs, keep in mind it could be hypertensive because that's a cause of heart failure, or it could be hypotensive because they're poorly compensating. And heart rate might be elevated to be able to compensate for the fact that they're not having a good ejection fraction, or the heart rate can be irregular because AF is a really common contributor to heart failure. Some other buzzwords to keep in mind for your exam findings is pulsus alternans. That's what this like diagram is here. Essentially, you'll have like one really strong pulse and one really weak pulse. So if you're like feeling their radial pulse, you'll feel like a strong one, a weak one, a strong one, a weak one. You can get an elevated JVP, and then when you push on the liver, you'll get that JVP going up even further. That's the hepatojugular reflux because you're basically pushing blood out of the liver, which is now all like saturated with blood, up the IVC and then up the JVP. You'll get Cosmo sign. So the JVP normally will increase on expiration, right? Like as you're forcing blood out of the or like your expiration, you're having increased thoracic pressure, blood is more likely to go up. But the Cosmo sign is that on inspiration, the JVP is going up, which is weird. You can get dullness or percussion bisally because of all the fluid retention, fine crackles and rails. That's like the classic term to describe heart failure sounds in the lungs. You can get displaced apex beat laterally, hepatomegaly, and we talk about pitting edema. Okay. I think it's really important to know the different New York classifications because you actually see this in practice quite often. So class 1 means they have absolutely no symptoms. They're good to go. Class 2 means they have some symptoms only when they're doing physical activity. So like out for a jog or like walking a steep hill, that sort of thing. Class 3 means that they're having impairment on their ability to do physical activity at a very like and also like some impairment on some day-to-day activities. So like if they're just going for a walk and they're quite short of breath. And then class 4 is symptoms at rest, which is very bad. In terms of your investigations that you want to order for someone with heart failure, you want to check their FBE, know if they're anemic. You want to see what their kidney function's up to, what their liver function's up to. The key ones here is you get an elevated BNP, so B natriuretic peptide, because that's released as a compensatory mechanism in heart failure. They can get low-grade troponin increase due to the myocardial stress. And then on ECG, you'll often see left ventricular hypertrophy as a sign, and then they might be in a weird rhythm, and they might have some Q waves visible from previous AMIs. The classic thing here is for chest x-rays of people with heart failure is you'll get these ABCDE signs. So let's go through them. So A is alveolar edema. So that's like this bat winging that you get. I don't think I included this in this image, but like you'll get like little patches of white out in the like way out into the periphery of the lung, essentially for those. Curly B lines, similar to that, but you'll get them in like longer lines. So like along here, cardiomegaly, so that's when your cardiothoracic pressure, your heart diameter is larger than half of your thoracic ratio. You can get dilated upper vessels, so like I guess like here a little bit and here a bit, and then your pleural effusion. So like you can see in between the lobes, there's like fluid here as well. You might also see more like bisally on another kind of X-ray. All right. In terms of management, let's talk about HFrEF first because this is the more common that you're going to encounter. So in the acute phase, you can give them furosemide to help reduce their fluid retention because obviously it's a very strong loop diuretic. It's going to draw a lot of that fluid out, so they'll improve their symptoms. But in the long run, furosemide is actually not that helpful. What is helpful though is changing their lifestyle. So we recommend 1.5 liter fluid restriction, daily weights to see if they are having any fluid retention, cardiac rehab, and like just improving their fitness, and obviously stop smoking. And when you're telling them about their 1.5 liter fluid restriction, don't forget to include things like ice cubes, really like juicy fruit like watermelon, and even like frozen things are considered like liquids because obviously by the time it's actually in your body, it's considered a liquid. So there are four drug groups that improve the actual like lifespan and prognosis for heart failure. This is vital to understand and to remember. So the first group are your renin-angiotensin agents. So of that, you have three. So you have your angiotensin receptor neprilysin inhibitor combination tablet. So that's sacubitril, which is the neprilysin bit, and valsartan. The second group that you have is your ACE inhibitors, and the third group you have is your ARBs. So those three are all considered to work on the RAS system. So you need one of the three of them. The second group that actually helps to improve lifespan is beta blockers. But the specific ones to heart failure are the ones written there. So bisoprolol, metoprolol, nebivolol, and carvedilol. And those ones you should start once they are at like a hypovolemic state, so that doesn't tank their blood pressure to then slow down their heart rate. But the benefit of beta blockers is it slows the heart rate enough so you can get better ventricular filling and stronger contractions. The next group is the mineralocorticoid receptor antagonists. So these are like your potassium-sparing diuretics. Spironolactone is the classic one. And the new addition is SGLT2s. This causes your glucose passage. Then it works like somewhat as a diuretic as well. So that's dapagliflozin and empagliflozin. So I remember when we were doing this, they always used to say like ABS puts the brakes on heart failure. So like ABS is the anti-lock braking system in a car. Um, However, now because they've added the SGLT2s, it doesn't quite work. So it's ABS with an extra S at the end. But you can remember that there's four wheels on a car, and there are four different drug groups that are vital for your HFrEF management to actually improve like life outcomes. Um, and all these four drugs should be started at the time of diagnosis, except for beta blockers until they're euvolemic. But even in like a younger patient who is like compensating well with their heart failure, these four things will help them to live a longer, healthier life. HFpEF management is much, much, much more simple. It's an SGLT2 for everybody, and to treat the underlying condition, right? Like if they have any comorbidities, really try to maximize your management of those. That's all you need to know. Fantastic. We got through heart failure. So next up is cardiomyopathy. So we've got a couple different kinds of cardiomyopathy to talk about. So you have your hypertrophic, which is where you get the thickening of the ventricle walls. You have your dilated, which is where you get thinning of the ventricles and dilation of the ventricle spaces. And then you have restrictive, which is generally when you actually have just like stiff ventricles because of some sort of depositing substances within them, or kind of like forming a band around them essentially. So HOCM, that's the hypertrophic cardiomyopathy. So that's genetic, as we talked about before. The most common one, though, is the dilated. Often it is idiopathic, but the other classic is like caused by alcohol. Can also be caused by like infections, hemochromatosis, that sort of thing. But like the classic is like someone who consumes too much alcohol. And then your other one, so restrictive, that's most likely due to autoimmune diseases. So like keep your mind out for like sarcoidosis, amyloidosis, hemochromatosis, sclerosis, anything that can cause like deposition into the heart. In terms of presentation, hypertrophic is going to be like similar to what we talked about before. So like sudden collapse, sudden death in an athlete, usually a young person who has a strong family history of similar sorts of events, and they'll get that S4 sound because of the blood hitting that hypertrophied part of the ventricle, as we talked about. Dilated, it'll get similar symptoms to like your heart failure, and you'll get that S3 heart sound because of the blood like has to kind of like fall like it's going into a glass, filling with water, hitting the edges because of that dilated valve or dilated ventricle. And then similarly for presentation for restrictive is you'll also get your heart failure type symptoms because you're getting really poor ventricular contractions, and they're more likely to have like an autoimmune history. The treatment for these is, well, refer to a cardiologist first if you have any sort of suspicion. But the treatment is usually a heart transplant for those really severe ones. Like if you have super severe structural problems, which all of these are caused by, that's kind of your only main hope. Like you can use medications in the interim, but once those all fail, that's how you go. Cool. Myocarditis. So myocarditis is just inflammation of the actual muscle layers, the myocardium. Most of the time, the vast majority, it's viral, and usually the culprits are Coxsackie and parvoviruses. Can be from rheumatic fever, like we talked about earlier. So that's like your GAS. Or it can be from some weird and wonderful things. So like lupus, sarcoidosis, Kawasaki is like a pediatric condition. Medications like clozapine can cause myocarditis as well. In terms of who gets it, it's usually young people. So like a young person that's presenting with chest pain, this should be on your differentials list. So the presentation is new chest pain, palpitations, dyspnea. They can get heart failure symptoms, like it can get quite severe. And usually they have some sort of indication that they've had a recent viral illness. So like flu-like symptoms for 1 to 2 weeks prior. So like fever, myalgia. So in terms of your diagnosis, how you actually do this, on ECG, you might see tachycardia, you might see some tachyarrhythmias. Just think about anything that can like be a result of an inflammatory process happening within the myocardium. You get global ST elevation. So remember before when I was saying ST elevation is not always due to STEMIs, it can also be due to myocarditis. And you might see some pathological Q waves from the inflammation and from the myocardial damage going on. In terms of your bloods, you'll get raised white cell count, raised CRP and ESR, and you can actually get an increased troponin. It won't be as crazy high as like if you had an AMI, and you can get some degree of increased BNP. And then the other classic is increased CK. So that's your creatine kinase, and that'll be the specific like muscle brain variety of that. The next stage is you do an echo because you want to make sure that like there isn't much pericardial effusion because as you can imagine, you have inflammation of the muscle that's drawing in all your inflammatory cells and causing some edema within the myocardium, but that can actually cause edema within the pericardial space. And then that can start leading towards tamponade. When you have myocarditis, you can also get like abnormalities in the wall movement because of the like inflammation of the heart muscle. So you want the echo for that. If it's super severe, sometimes you might do a cardiac biopsy, and you can see like all the inflammatory cells at work there. So this was us talking about on the ECG, getting that like global ST elevation. So like you can see it in lead one, you have some ST elevation there. You can see it in lead two, there's definitely ST elevation here, and lead three, and you're getting like some depression here. That's pretty okay. AVF definitely getting some ST elevation, right? Like all these have some degree of ST elevation, and it's not following one of the patterns that represents one of those like vascular regions. In terms of management, it's important to diagnose this and to monitor it early because myocarditis is the cause of death in 10% of young adults. Sudden death, right? So you can get really severe myocarditis that just essentially causes you to go into an arrest. Um, where you can, you want to treat the underlying cause. Obviously, it's tricky if it's viral because you just have to kind of monitor it. And interestingly, normally when someone has a viral infection, we say like, oh yeah, you can give some like anti-inflammatories to help with this. However, in this case, you don't want to be giving any NSAIDs because they have a risk of fluid retention. And obviously, if you're already having like myocardial problems, you don't want to be doing that. So to treat the symptoms, you want to be sticking with paracetamol where possible. All right, and we're moving on to pericardial disease now. So talking about pericarditis first. So similar to myocarditis, but now it's just inflammation of the pericardium. You can get this acutely, or you can have chronic as well. Similarly to myocarditis, it's most likely viral, and it's the same culprits, usually Coxsackie, potentially parvovirus. The other common cause for pericardial inflammation is post-AMI. So there are two different types that they talk about sometimes in pathology. So 1 to 3 days after having an AMI, you can have fibrinous changes in the like area where you have an infarct, which can cause pericarditis. That's like that early kind. And then there's something called Dressler's, which is like an autoimmune response to the damage that's gone on in the heart. So that happens like weeks to months after having an AMI, and that can also cause pericarditis. The other causes are like things that cause some deposition. So like if you have chronic kidney disease, you can start to get uremic buildup actually in the pericardium, which causes pericarditis. And then your autoimmune causes as well. So the classic presentation for this is pleuritic chest pain, because again, you're having the inflammation of I'll go back to this image actually. You're having inflammation within the pericardial space. So that's going to cause inflammation of the visceral layer and the parietal layer. And again, the parietal layer is going to be having that like rubbing effect, which causes like that pleuritic type chest pain rather than just being like a deep crushing chest pain. The pain's also going to be worse leaning forwards because you're going to have more irritation from the heart rubbing onto like the sternal area. You might get a low-grade fever. And then the classic sound when you're auscultating is a friction rub. So it's described as like a high-pitched scratching sound, but I put a hyperlink in there if you want to have a listen to it. Personally, I don't think it sounds anything like that, but maybe I'm just not great at auscultating. If the presentation is quite severe, then someone can present with symptoms of heart failure. And worst case scenario, they might present with symptoms of tamponade. All right, so the diagnosis for pericarditis is that you need two of the following four criteria. So the characteristic chest pain, so like pleuritic and worse on leaning forward, the friction rub, an echo to show that there is a pericardial effusion, and then the ECG changes. So let's talk about the different kinds of ECG changes that you can see. So one of the common ones is the PR depression. So if you draw like a line going across, you can see that these PR intervals are a little bit lower. I think this one's a better example because it's like much lower. Like here's your baseline between like the T wave and the P wave. You can see that PR is like a good box lower. The second change that you can see is this like saddle-shaped ST elevation. So we know that some other ST elevations don't really like dip down like that, like they'll just kind of go across, but these saddle-shaped ones are pretty pathognomonic for pericarditis. Um, yeah, you can also get some ST depression. I wouldn't worry about that. In terms of the management, you just treat the underlying cause and then rest. In this case, since the problem is in the pericardial area, not with the actual heart muscle, NSAIDs are fine because if they have some fluid retention, their heart is still pumping okay enough to like manage with it. Like this is less likely to kill you unless you have like a massive pericardial effusion. Speaking of which, effusion's tamponade time. So tamponade is when you get fluid in the pericardial cavity. Well, sorry, that's an effusion, right? Like pericardial effusion is when you have fluid in that cavity. But then once it gets to the point that it causes restriction of ventricular filling, that's when it's considered tamponade. And that's when it becomes a medical emergency. So your causes commonly are like a chest trauma, right? So as you can imagine, if you had something that like pierced through the heart, then you're going to have some blood leaking into the pericavity. That's your hemopericardium. So when there's blood filling it, similar to like a dissection, you're not going to be able to get that blood pumping properly. Dissection, post AMI, you can get a wall rupture. We can go back to that pathology slide, and it's like within a certain number of hours or days. I cannot remember. After cardiac surgery, and then if someone had pericarditis, as we mentioned on the last topic. So classic for tamponade is the Beck's triad. So I think this is important to remember. So there are three things that are going to make you very highly suspicious that it's tamponade. First one is going to be increased JVP. So if you think about it, the heart's not being able to fill with blood normally because you have that fluid in the pericardial effusion area. So because of that, blood is going to backflow. So it's going to go like stay in the IVC and then start going up the SVC as well. So that's why you get that elevated JVP. You have muffled heart sounds because you've got this like protective layer from all of the fluid that's around the heart that's going to be muffling it. And then you're going to get hypotension because again, the heart's not able to let blood in to be able to pump it out. So you're not going to have proper blood pressure. So if you get these three things, the other symptom that you can have, or like sign you can have, sorry, is pulsus paradoxus. So this is when on expiration, so you're breathing out, you have like a larger pulse difference, and then on inspiration, you get like a smaller pulse difference. But if you just remember, like pulsus paradoxus is something you can get in tamponade, that's probably good enough. So generally, if someone has those symptoms of Beck's triad, you go to like the urgent management, which is pericardiocentesis. So put a needle in, take the fluid out. Makes sense, fixing the problem, and then obviously like fix whatever's actually causing it. But if you're unsure of the diagnosis because they don't fulfill all of Beck's triad, you do a POCUS. That's a point of care ultrasound. So that's like an urgent echo essentially. So in that, you want to be looking for that effusion. So like if you look here, there's the left ventricle, there's the right ventricle, and then this huge black space is all the effusion. So like you've got more blood or more fluid in the effusion area than you do in the heart space. So that's a big bad problem. So that is everything. That is your cardio matrix. I hope you found this helpful. As I said, my email is there, if there's any issues with anything. We are going to be doing an in-person question and answer session coming up. So do not fret that there are not questions here. There's going to be an in-person session for that at Clayton. For rural students, I believe we're going to be able to do it via Zoom, or you'll have access to them. I will ensure that. Yes, if you have any questions about anything related to third year or potentially fourth year, also about rural stuff, because I've been rural the past couple of years, please let me know. I'd be happy to help. All right, good luck on your exams.